Sì, ok. Io ci sto. Sto sul 2. Sul 2. Sì. Non arriva niente. Provo l'altro. Eccolo. Nemmeno questo. Prova questo. Prova, prova, prova. Ok, ok. Ce l'ho. Ok, ok. Sì, sì. Prova. Ah, ok. Ritorna anche in sala. Riprovo anche di nuovo l'altro. Sì, prova, 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 prova. Sì, sì. Ok, prova, sì, sì. Eccola. Eccola lì. Va bene.
visto che fa uno studio, non conviene togliere dei mezzi in radio. In radio non conviene togliere dei mezzi.
Radio, secondo me sì.
Perché sennò dopo c'è un comportamento automatico.
Questi qua si devono là.
Avevamo questo qua. Perché sennò dopo se pisciamo troppo su questi cominciano a andare in giro.
Provate a distrazione con la vostra, mi fate come lascia acceso il pannello sul canale 2, per favore. E Andrea non trova.
Sì, no, sono rimasto dentro. No, se cominciano ad andare in giro. Yes, eccolo. Prova 1, 2, 3, sa. Ok.
Chiedo scusa. Oddio, aspetta. Oddio, qua ci
Attenzione.
si ammazza, sì. Sì, sì, posso lasciare qua, tanto lei non disturba, no?
No, 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 abbiamo solamente fatto le prove.
Ok. Usciamo tutte e due, vediamo se si riesce, no?
Prima lei, prego, prego, prego.
buongiorno.
Buongiorno.
Scusi per un
Prego,
attimo.
prego.
Salvatore, mi senti? 1, 2, 3, 4, 5, 6, ok. Spengo? Lo spengo? Lo chiudo?
Ok, 1, 2, c'è. Prova. Questo è inglese. Canale 2 inglese. Sì, sì,
Ok.
sì.
Perfetto, va benissimo. Prova questo pannello. Perfetto.
E canale 2.
Grazie mille.
no, però mi è sparito il cavo VGA. Ma che l'hai utilizzato tu, scusa? La fai?
Sì, sì.
Sì o no?
Sì, sì, sì.
La stai sul pezzo?
No, ero perplessa, ma non si può. No, in realtà è uguale a quello.
Ok.
Ma il metodo non va avanti. È bello questo qua.
Che corre per i lavoratori che arriveranno col Mac adesso ti accompagno su così.
Sì, la penna non ce l'hanno messa questi. Dio.
Sì, infatti adesso
Guardi un po' se mi piace.
È abbastanza centrale.
A destra Valentino.
Sì.
A sinistra Russi e... come si chiama? Vabbè.
Io vi lascio anche modo di da filmare.
Prova.
Vincenzo. Marta Melli.
Sì, prova, prova. Sì, ehi, prova, sì. Ehi, ehi, sì. Ok.
E controlla un po' se ti arriva. Dovrebbe già arrivare.
I'm just checking.
Okay, perfect. bravissima. Francesco, aspetta, mi rimetti il tappo iniziale sul video, il tappo iniziale.
Sì.
C'era il microfono.
Buongiorno a tutti, vi prego di accomodarvi perché stiamo per iniziare. Buongiorno, abbiamo
Good morning. There will be a simultaneous translation, so for those of you who would like to have headset, good morning. Thank you for your attendance, probably which shows a very small room. This is the 4th UPMC International Conference, the 2nd conference in Rome, focused on stereotactic therapy, radiotherapy, the increase of pathologies forced the government and healthcare centers and agency together and find strategies to contain this kind of pathologies and also containing costs. About 25 million new cases in 2015 with an expense of $3 billion. Radiotherapy nowadays is one of the chances that, besides being effective, is also sustainable from the financial viewpoint. Surprisingly, radiotherapy in
abbiamo
developed
ancora una
countries such as
bassa
Europe
percentuale di
is
distribuzione di centri di radioterapia.
enough spread.
Perché la stereotassi? Ultimamente, come potete vedere, negli ultimi anni c'è stato un notevole interesse e anche un aumento della diffusione nei centri di questa metodica. E ci siamo chiesti perché. Sicuramente facilitata dalle innovazioni tecnologiche, in parte forse anche
with technological innovations. Partially these investments are justified. It gives more compliance to the patient. One of the most challenging side effects was deleted, such as the duration. Physicians and oncologists are very happy to send a patient to see a patient after 1 week with a decreased toxicity, sometimes totally gone toxicity, and this is another efficacy which is a benefit for patients. This is something that has to be studied. There are some pathologies such as several tumors that respond very well to this kind of therapy. Basically, we don't know any aspect, all aspects leading to this kind of response, but the dissemination of stereotactic therapy led to diversified prospects. Maybe we need more organization, more training, more education. So all these events now are becoming necessary in order to implement the use of this technique. So I now give the floor to the president of our national society. Thank you for the invitation. The topic is very important, that's very interesting, not only for what we can do today, but also because we need to understand how to introduce this subject within multidisciplinary teams. Nothing is given for granted. Sometimes new medications that have never been tested with radiotherapy in general are used by our association. So we, radiotherapists, we need to know the criteria and the methods to use these so-called weapons. We want to reduce the treatment, and we want to go back to our old dreams. So delivering a therapy to a patient without surgery. And technology nowadays allows us to do that. We saw that if we move the dose intensity, we trigger some abscopal mechanisms that can interact with the rest of antiblastic therapies and new medications. in a very positive or negative way. So, we must also look at what is going on in the oncological market, interacting with our interactions. So based on our discipline, we must know the risks, maybe in advance. This morning, this news, this morning, Professor Milazzini has been appointed as the new president of IFA. We'll try to contact him as soon as possible in order to have his opinion on medications which have never been tested before. So this should encourage new studies and research with the support of pharmaceutical companies in order to spread our researches and discoveries. Our friend Piercarlo is doing a very good job. We wish him good luck and to welcome and gather so many people as this year and the previous year. Thank you. Good morning. I'm talking on behalf of the region of Lazio, Molise, and Abruzzo. Welcome, and thank you, Piercarlo, for the organization of these two beautiful days focused on a very interesting subject. I don't want to add anything more after Piercarlo and the president, Airo, but just a promotion for the team of Lazio, Molise, and Abruzzo that will meet in Rome to discuss about the control and delivery of the treatment. You'll see the program in the afternoon, so I'm not taking some more time. Just another thank you to Piercarlo and his staff, and welcome to my colleagues coming from abroad who gave us a beautiful contribute for these 2 days. And I give the floor to Vincenzo Valentini. Thank you. I think all the interventions before me focused on a sentence that for about 10 years has been proposed. Act locally, think globally. Stereotactic therapy is a winning model. As the American authors had proposed to the scientific community, stereotactic is a very local therapy, but we need to think globally in order to aim to the right target from a multidisciplinary viewpoint. So today, we'll see this perspective. We'll see how to optimize this locally therapy. I wanted to thank again Piercarlo, not only for the organization of this event. This is the 4th edition. It starts becoming a tradition The tradition is something to share, something appreciated by the audience, but Piercarlo is also a young man who started this very complex pathway. He's working in a private facility, but he opened himself to international collaborations. This is a very complex pathway because he has to face different cultures. American culture, as we know, has different logics and methods that must be integrated and included in an Italian reality, which sometimes is not so similar. But also, culture is so different. I'm not saying that we should have the same values, but the integration still is not very simple. So we have ethical problems, relationships problem. The experience is not in Italy only, it's in Rome, in a very complex city, from many viewpoints. So it's now like surfing in this pathway with a bright mind. So I want to recognize this talent. I esteem Piercarlo a lot, except that he supports the Milan football team. But, you know, we appreciate what he's doing. So I wish you all 2 beautiful days. Thank you, Piercarlo, again. Thank you, Vincenzo, for your beautiful words. So you'll be the moderator for the next session.
Bene, allora mi hanno detto che di continuare.
So I'll be the moderator for this session. That will put the basis for act locally, so doses and volumes to deliver. Speaker speaking English.
On having an overview what is going on in Europe about stereotactic radiotherapy. Who is Martin Hoyer? He's a scientist coming from Aarhus. Aarhus is a center that is in the West Denmark that we know very well for the signature that this center left in the European Society of Radiation Oncology, because many clinicians and researchers that are there have a great impact in the scientific dissemination of our Radiation Oncology Society. Obviously, namely for myself, past president of Estro, Aarhus is tied to Jens Overgaard, but it's not only Jens Overgaard with his commitment to promote this great journal that is the Green Journal, but it's also a large community of scientists that take care also to think globally, to move from the dose delivery to the radiobiology and biology that is behind, to the complexity of multidisciplinary cancer approach, and never forgetting the value that all these efforts are committed to serve patients. And I think that Morten will help us a lot not to lose this perspective. Act locally, think globally. Martin Hoyer, please.
Thank you very much for this very, very kind invitation, and thank you so much for the invitation to come here. It's a great honor for me to give such a lecture. I know it's a great responsibility as well, and I see whatever I can do to fill in this responsibility. I'm really looking forward to 2 very interesting days here in Rome, and especially for the nice Rome and also for the sunny weather here, because I can tell you the weather in Denmark is awful. It's raining, it's cold. Now, I was asked to talk about doses and volumes in SIS and give it a European perspective. And so what should I then do? I could give an overview of whatever is going on in SBRT or in SRT of the brain, but I wanted to be more kind of specific, to give it a kind of a more comprehensive kind of view into a specific field of SRT or SBRT. SRT is in brain, SBRT is outside the brain. So I thought that when I was giving this list title, then it was more about the brain. And if we're going to study the effects of radiation therapy in brain, then it's about tumor control or it's about morbidity. If we really want to study morbidity, then we are hampered by the very poor survival if we are studying metastasis. So I want to study something or give some lecture in something where we could actually have some more long-term effects. And for that, I had to look at the benign tumors, and one of them could be the AVMs. And then I have the responsibility also to give a European perspective. And I know that this will not be possible simply without also mentioning some studies, important studies, and from the United States, and especially from the UPenn. So please excuse me for also giving some studies or showing you some studies from North America on the ways. Now, what is an AVM? An AVM is a kind of congenital tumor of small blood vessels, small capillaries, which is along with the larger vessels, with the veins that we have, kinds of forms a tumor. Because of the shunting over these vessels, there might be a kind of a cerebral steal phenomenon, meaning that there will be the adjacent kind of the brain will be in a hypoxia state. And this actually causes the symptoms, which can be headache, seizures, paresis, numbness, and then also because of this fragile nature of the small vessels and the high pressure that you have, there's a risk of bleeding as well. And this is one of the very important things about the AVMs. That's the risk of a hemorrhage that can be in the average of a few % per year. And if you have a young person who has an AVM, you can actually calculate the kind of lifetime risk for such a person to have a bleeding, which could be 105 minus the age of the patient. So if you have a 35-year-old man with an AVM, then this man might have a lifetime risk for a bleeding of approximately 70%, which is very high, and which gives this man a high risk of morbidity. And if the patient had one bleeding, then the risk for having an additional bleeding is really high. So there's a lot of factors that might be related to the risk of having an hemorrhage, which could be the patient's history of hypertension, a history of a previous hemorrhage, as I just mentioned it, and it could also be factors related to the architecture of the AVM, which could be the flow, which could be an aneurysm which is within the nidus, which could be a deep venous drainage, could also be the position of the AVM, and even some smaller AVMs have a high risk of bleeding. Then it's the pressure and the feeders and the kind of calibration of the feeders. It's also the filling of the AVM when we are doing angiography, and it's the venous stenosis. So there's a lot of factors related to the risk of bleeding in these patients. Now, what can we do about them? What is the treatment of AVMs? Well, it's microsurgery, which has been the kind of preferred treatment of these patients. It could be endovascular procedures as kind of embolization of the needles, or then radiotherapy in terms of single fraction radiotherapy, which is the preferred type of radiotherapy. So let's just briefly go through them. Microsurgery is highly efficacy, or it's had very high efficacy if you can remove it. And of course you prefer to remove the superficial ones or the smaller ones. There's a very high efficacy. Approximately 95% of these can actually be removed, and morbidity is related to the position of this AVM and of the size, etc. But usually it's within, let's say, 5% risk of a long-term morbidity. Embolization, this gives you an example of an AVM, which you can see right here. And after embolization, they put a catheter, and they can actually use a very highly specific, they can actually take the catheter into the feeding artery of this AVM, and they can actually, by injection of a glue, they can just embolize it. And you can see this is the results after the procedure, just a small remnant AVM after that. So it's possible in some cases, but not in a large number of cases, to make a total obliteration, but only approximately 10% of the cases can be treated like this. In the rest of the remaining of them, there will be only a partial obliteration after the procedure. And it might be good because you may be able, and that's been kind of the motivation of doing it, you can actually reduce the volume of the needles, and then you can actually treat the patient afterwards with radiation therapy, and you don't need to treat such a big volume, you can reduce the volume. That could be good. The good thing about the pre-radiotherapy embolization, the bad thing about it is that you might actually blur the imaging of the AVM, and might be even that the complication rates increases because of the kind of combination of the two treatments. And then we have the stereotactic radiotherapy, which is not a very new thing. It was invented by Lars Laxell from Stockholm, who actually used protons in the very early days. And what he did was that he had this kind of stereotactic external coordinate system that he used for guidance of his protons. Problem was that it was not a very easy thing to work with, and so he kind of worked further through it and made this, as we know, the gamma knife. And this is the old version of the gamma knife, but the new version of the physician. As you can see it, they installed this in '68 in Stockholm, and this was the first version of it. And already in '74, they treated the first patients for AVM. And they reported on these first 5 patients with AVM, which were successfully treated. They also gave the recipe of how to do it, how to mount the kind of collimators for the gamma knife on the patient, and how to use the angiography for guidance of the treatment. So this was very well described, and this has been actually the kind of way that we have been doing it and still do it today. However, we would prefer in many places to use a LINAC, and this also gives the opportunity to a lot of people to do LINAC-based stereotactic radiotherapy. For that you need a mask or invasive frames to kind of have a very firm and safe immobilization of the patient. You need the coordinate system, and the reason usually we would use a cone beam CT to set a patient up when we do stereotactic radiotherapy, but in this case where we want to have the angiography for guidance of the treatment, then we have to kind of do the fusion of these 2-dimensional images to the 3-dimensional CT scan, which may actually not be possible unless we have a kind of fiducial system based on which is attached to an external coordinate system for definition of the target and later on for kind of setting up the patient at the treatment machine. So this is the way that we do it. Usually we will be guided by a CT, by an MRI, and by angiography. So how about the success rate in SRT? Well, the success rate is high, usually 60 to 90%, and the patients that we treat with SRT usually have a larger MRI or a larger AVM compared to those that are treated with surgery. So it's actually not a very bad results that we can have with SRT. It's actually very good results. But latency period before the AVM obliterates is approximately 2 to 3 years. So it does take some time before we have this success. And there is a risk for bleeding within this window between the treatment until the obliteration actually goes on. Complication rate, as I mentioned it before, approximately 5%. So very kind of comparative to what we see after surgery as well. Now, what are the outcomes after radiosurgery? We can compare that to the outcomes after surgery and after endovascular procedures. Now, the first line, as you can see them up there, is surgery. You can see it gives you excellent outcomes. The red ones are the best patients that had full functional outcome after the procedure. The green ones are the next best. But if you look at the blue ones, they're the disabled. They're those who actually had very severe morbidities. So this is after surgery. How about endovascular procedure? That's the next line. You see it's not as good, but it's actually very good. There are few patients with grade 4, only 5%. Most of them have very excellent outcomes. How about radiosurgery? It's the third line. Well, it gets less good. The best group, the red one, is only 2/3 of the patients. Now you see there are more patients with the intermediate results, those that have moderate morbidity after treatment. And if you combine, meaning if you do endovascular procedures followed by SRT, it gets less bad, less good. And if you do nothing, which is one of the fifth line, well, it's actually very bad. You have a lot of patients who have moderate to severe problems in the long term. So which is best? It seems that surgery is best and conservative therapy or management is terrible. But which are actually which? I mean, what patients are in the groups? They're not comparable. They're very different. And if you look at the different groups, they actually differ a lot. Usually we would use the Spetzler-Martin grade to kind of give the patient a kind of an assessment of the AVM, pre-treatment assessment of the AVM. The Spetzler-Martin grade is a surgical risk assessment system. It's not for radiosurgery, but it's actually used by a lot of people just to give a prognostic index of the patient's pre-treatment. The Spetzler-Martin grade is a kind of a combination of the size of the tumor. You can see that means a lot because it can give you 3 points, and you actually look at the sum of the points, so it actually means a lot. The size is very important for this grading system. Then the venous drainage, whether it's superficial or it's deep, gives you 1 point, and eloquence, meaning whether it's an eloquent area that has some effects or not in the brain, has a function in the brain, gives you 1 or 0 points. So a total you can have between 1 and 5 points. And if you look at the surgical patients, they are all grade 1 and 2. If you look at the endovascular managed patients, they're 1, 2, or 3, a few 4. But if you look at radiosurgery patients, they're almost all of them grade 2 and 3 patients, and even some grade 4 patients. And the combination gets even worse. And if you look at those that are handled conservatively, there are almost all of them in a very high grade, meaning that they also had a very high risk for bleeding. So what I showed you before is not actually giving you the kind of results after each of the procedure. It's more or less attached to or a result of the state of the patient's pre-treatment. I think that's a good lesson to learn now and to actually bring into each of the different areas of SRT, because it's a very important thing to keep in mind. Now another study, I think very important study, this is a meta-analysis of 140 cohort studies with more than 13,000 patients, a lot of patients. They looked at the case fatalities, they looked at the risk of a hemorrhage, and they also looked at a severe complication. You can see the red ones are surgery. So with surgery, of course, there's a surgical risk. But there's no risk of a post-surgical bleeding because they've removed the AVM. If you look at radiotherapy, which are the blue ones, you can see there's almost no risk of case fatality, but there's a risk of hemorrhage within the next years after the bleeding, or after the procedure, after the treatment. And complication rates between surgery, which is the columns at the right, surgery, radiotherapy, and embolization, endovascular procedures, there are around these 5%, each of them. So what should we do when we have the next patient that we have to decide for the treatment? Well, we have to do it in a multidisciplinary environment. We have to consider the patient's age, comorbidity, symptoms, the previous bleeding history, the clinical risk factors, the risk factors which are related to the results of the angiography, the previous treatment that the patient had, and then also what the patient prefers. So this is actually what should be considered when we have the patient. But we have the belief that we need to treat the patient if it's a young patient and if he has a high risk for a bleeding that might actually be disabling for the patient. So I think we all had a very big surprise when we saw the results of the Aruba trial. The Aruba trial actually randomized patients between active management with microsurgery or SRT or endovascular handling or procedures in one arm, and the other arm, observation, conservative management. And we expected that by this act, we could kind of avoid a bleeding episode or a stroke of the patient. But the problem was that the opposite was actually found. There were more strokes in the group of patients that have an active treatment. So how could that happen? There's only a very short follow-up of these patients, so maybe we need longer follow-up to see the results of our active management. You could also say, would you randomize a patient that you really feel should be treated? Maybe the neurosurgeon didn't want to do that, and I can really understand him. That's another thing. And you can also look at the blue lines up there, or the graph. Is it really what we expected to have a more than 30% risk of stroke in a patient group that are actually managed? We didn't expect that. And so there's a lot of discussions about that trial and what it's showing. And this just gives you what kind of intervention that we used in this, the active arm. So it's very important that we, in each case, kind of balance the effect that we can expect from the treatment to the risk of complication. And I think it's very importantly that the treatment that we offer to the patient should not harm the patient. So it's a very, very delicate balance. And I don't know if you read the book by Henry Marsh. The way he looks at you, you know he's a surgeon. And he actually just tells you that a surgeon might sometimes have a difficulty in sleeping in the night because there's a very high risk for the surgeon that he has a complication, which he actually realized immediately. For us, it's something that may happen over years. Now let's look at the obliteration kind of chance after SIS, and there's a very comprehensive analysis of this where they looked at factors related to the patient, related to the AVM and the treatment. They looked at a lot of very important prognostic factors, and there was a lot of them actually related to the obliteration, the chance of having obliteration in the univariate analysis. Just look at the multivariate analysis. Yes, volume actually made a kind of a factor. The larger the volume, the lower the chance to have an obliteration. And also the dose meant something. The higher the dose, the better the chance to have an obliteration. And especially when you looked at the marginal dose, the lower dose, telling you that you should actually get to some dose before you can have a chance for an obliteration. If you don't get a complete obliteration, it's a failure. You need the obliteration of the whole AVM before it works. And volume actually meant something. You can see on the blue ones, these are the successors. This is less on the first column, less than 1 cubic centimeter, 1 to 5. And when it goes over 5, it drops. There's a lower chance of having obliteration. So volume means a lot in terms of obliteration. And dose means a lot. If you look on the left column, you can see there are two curves. The one to the right is the median kind of dose. The one to the left, or the average dose, one to the left is actually the marginal dose. So it means a lot. The higher the dose, the better obliteration you can have. And the faster it goes before it obliterates, which is shown to the right. It's also been worked as Ben Carlson, who used to be in Sweden, has done a lot of work here. He later on went to Frankfurt and then to Virginia, and now he's away to the Far East. But he's doing a lot of work in here, and he looked at the minimal dose, again the marginal dose, and the volume to the right, and you could see that the risk for a bleeding in the window before the AVM obliterates is very much related to the dose you can give and the volume. The red up there, they are 6 to 8% risk. And this is in a patient who is approximately 40 years old. If you get to an elderly patient, the risk for a bleeding within this window is much higher. So all these curves move down and to the right. So the risk increases. So should we treat them in one fraction? This is what we do. Should we kind of instead, should we maybe then try to fractionate the treatment, because that might be more sparing of the normal brain tissue. So we need to know what is the alpha beta. We expect intuitively that the alpha beta is low, so that we should treat in one fraction because it's a kind of a normal tissue. And there's a lot of contradicting kind of data out there. If you look at this data set from Germany, it seems the alpha beta, and this is just the way that we calculate it on these graphs, might be 3 or 3.5 or something, but other studies actually failed to kind of calculate an alpha beta because they simply didn't fit into the models. So it's not a very well answered question. We don't really exactly know the alpha beta of an AVM. So this was about the obliteration. What about the other part of this balance, the complication? I showed you this before, and this study with all these 13,000 patients, they looked at the risk for a morbidity of the patients, and it is approximately 10,000 patients in this group, so it's a large group of patients. They found some factors related, and especially the volume of the needles was related to a high risk. A high volume is related to a high risk of a morbidity, and the marginal dose there. But it's in worse. If you're not really able to give a sufficient dose, then you have a high risk for bleeding. So you need to have a sufficient dose in order to have a success, and I think that's very important. You cannot compromise on your dose So that's really important here. Now, looking at imaging, we can also study morbidity there, and this gives you on the upper columns the changes that you have from the pre-treatment to the post-treatment of the edema that we see. That's the most frequent kind of morbidity that we can see on an imaging. We do also see some enhancement after contrast injection, but really that's just a kind of a secondary thing in my mind. And then there's a risk of a cyst formation, which we can see in the very long term in a few patients. It's not something that we very often see. I've seen a few cases with that, but it's not something that we often see, and it's very much related to the cases when you give a very high dose. Now, if you look at these post-SRT changes on MRI, some of them are actually related with symptoms, and some of them are just something you can see on an image. The kind of broken line that you see below on the left panel is patients who have a symptom related to a kind of a simultaneous changes on the MRI. And then you can see the full line just shows you patients who have something to be seen on an MRI. And it's very much related to the dose that is given to the brain. And this is a study which is presented here by Flickinger from the UPenn. I think a very important study showing that what really determines the risk of a morbidity is the volume that receives 12 gray or more. I think that's very important. It's not necessarily the volume receiving the very highest dose, but the volume that receives maybe the intermediate dose or 12 gray or something. I think that's very important, and we have actually used that a lot when we are considering treatment planning of a patient with an AVM and also even with metastasis. So some of them may recover the time. Patients with mild symptoms may recover the time within 2 or 3 years after treatment. If there are more severe symptoms or if the patients are disabled, they have a lower chance of recovering. And the risk is very much related to the localization of the AVM. If it's localized centrally in the pons, in the midbrain thalamus, and also occipitum, in the basal ganglia, in the medulla, in the corpus callosum, they have a high chance of risk for a morbidity, whereas if it's in the frontal lobe, temporal lobe, the risk is much, much lower. This was also studied by Ben Carlson, who looked at patients with peripheral or central, and he found that there's a much higher risk for a morbidity if he has a kind of a central lesion. What he found, and what I find a bit surprising, is that the risk is also related to whether the patient had a bleeding pre-treatment or not, and those who actually had a bleeding had a lower risk of a morbidity. I would have expected the opposite. He tries to explain it by the kind of appearance of gliosis or scar tissue around the target that may actually not be so radiosensitive. I would say that it could be related to the low number of patients who did not have a bleeding before treatment. So there's a high risk of something just appearing by chance. So some of these patients have very, very large tumors. We saw it on the image where you saw how many patients who actually have are handled conservatively. And if you have these very large AVMs, it can be very difficult for you to give a sufficient dose, and there's a very low chance that the patient may obliterate and have a successful treatment. So what could you do? You could fractionate, and this has been done. This is also shown by Ben Carlson. I have to admit again that that was after he left Europe. I think this was from West Virginia. And he showed that in this group of 28 patients, only 2 of the patients had a successful treatment because of this very large volume and the kind of low chance that he had for an obliteration. And that's a problem that we have, especially the patient have a poor survival, and especially if they have a hemorrhage, had a hemorrhage before treatment. You could also do a two-stage procedure, which was shown again from the European group, where you treat one part of it first, then wait half a year and treat the other part. And that has been very successful in 37 patients, where 50% of them had a successful treatment. Or you can treat by particle therapies, which, and you can see up the top picture here, which is the Danish particle therapy that we are actually setting up in Aarhus. So my heart is very much with the protons. Protons may be very good for the very large, because you have this advantageous kind of dose distribution with protons, but it's not very good for the very small ones, because you're actually painting with a broad pencil because of the lateral penumbra of the protons. But there are actually studies out there suggesting from South Africa and from Japan that you can have very good results on the very large, and even studies also with helium, the more heavy ions from Berkeley on the very early period, again from North America. So there might be an opportunity there. So this brings me to the conclusion that whenever you see a patient, there is a for and against treatment. And the for is that we may actually prevent a hemorrhage. Against is that the risk of having a morbidity related to this hemorrhage may not be as large as we previously thought it was. Some newer studies showed that it may actually be lower, and the risk that we take by treating the patient is there. We have to keep that in mind. So for each of the patient we should treat, we should consider his age, comorbidities, symptoms, previous history of bleeding, hypertension, previous treatments, and clinical risk factors where volume and dose is very, very important, and of course the localization, also the architecture that we have on angiography, and the patient's preferences. And then we should know, which is always there when we are talking radiotherapy, that the studies I just showed you are based on old technology and imaging, and now we can do much better. So thank you.
Thank you very much for offering such a model to understand the relationship between dose, volume, and risk for patient, and to put it in a very comprehensive perspective. In the interest of time, I think that we have to stick in 30 minutes. So because we spend 30 minutes, so we have no time for questions. So I'm really happy and glad to go to the following speaker, and I would like to invite Dr. Klamp for give his talk on what is the major experience in USA.
Thank you very much for inviting me. I'm going to present a little bit on our perspective and utilization of radiosurgery, or SBRT, primarily focusing on an overview of multiple applications that we see nearly daily in our clinic. So this has really been a transformative technology that where we've been able to bring a focused radiation approach that we've been using in the brain and integrate it into that of the body, and really improve upon the lives of our patients. So we're now treating over, I think we're up to around 10,000 patients now with our LINAC-based platforms. So we'll talk a little bit about stereotactic ablative radiation therapy as part of this talk. When I started this, it really keeps coming back to this is a team-based approach that we utilize here. So it's a combination of that's really been adapted and accepted by our colleagues through medical oncology as well as surgical oncology. We work in close partnership with the radiologists to help us delineate and target these lesions, as well as our supportive services. So it's almost an acknowledgement slide from the very beginning. What's not listed here is really where I think we're going with this field, is how can we integrate in our colleagues in radiobiology and our scientists to really transform the way that we do translational research and introduce new treatment paradigms for some of these patients with oligometastatic disease, and convert patients that were previously just managed with chemotherapy and palliative approaches with more of that of a definitive approach. So similar to the last talk, I mean, much of this starts with the work of Lars Lexel and the application of focused radiation within the brain. And it really wasn't until we developed technology that allowed us to move outside of the cranium and an immobilized target to that of the body that we've been able to introduce this treatment into tumors such as lung cancer or head and neck or even prostate. All of this comes down to, regardless of the technology, our ability to immobilize the patient, visualize the tumor, and then utilize the technology to deliver a highly focused, reproducible dose of radiation, and at least in the United States, over 5 fractions on non-consecutive days. The technologies that we use primarily in Pittsburgh, and there's certainly more listed throughout, but we utilize the Trilogy units and the TrueBeam platforms, which are provided by Varian, as well as the CyberKnife M6, which I saw a nice picture of when I walked in. But regardless of the technology, it really comes down to our ability to, again, visualize the tumor. Either they're utilizing a surrogate for the tumor in the case of the CyberKnife, or introducing immobilization masks and cone beam CTs for the TrueBeam treatments. In terms of motion management, we often utilize the RPM software, and we are doing a little more breath hold technique more recently. The CTC simulation process and the requirements that go into immobilizing and determining motion management are of utmost importance. In our center, we use tumors that are moving over 5 millimeters. We will use respiratory gating techniques for these patients, and then just use a target ITV approach for those with less. So in terms of opportunities and how we move forward, certainly patient selection and preserving patient quality of life is key. There certainly can be a complementary treatment modality, and I'm seeing more and more that medical oncologists are referring patients to us to complement their effective therapies as they're seeing partial response in many of these tumors and the introduction of immune therapy. How can we potentially augment and improve upon the current responses? And certainly, how can we integrate in translational models where we can actually study some in a novel approach to the radiobiological process? Thank you. So currently, in terms of definitive therapies, we're delivering this in the setting of lung cancer, prostate cancer, pancreatic cancer, and also in the salvage setting for recurrent head and neck cancer. And then in oligometastatic disease, which I find it probably the most rewarding, is how can we augment what our medical oncologists are doing, providing more of a durable response and potentially reinstituting checkpoint inhibitors and restoring sensitivity to these therapies. And of course, as we've talked about for a long time within the field of radiation oncology, the aposcopal effect. This is a novel time that allows us to actually biopsy patients in a sequenced approach in combination with checkpoint inhibitors to get an idea of the immune infiltration within these specimens and potentially, again, restore sensitivity to the innate immune system. So we're utilizing SBRT throughout the body, from head and neck all the way down to the prostate, and also within the setting of reirradiation for bone and soft tissue malignancies. I'll go through some of these today, and I often start with, when we talk about SBRT, I start with our initial experience within lung. Certainly this isn't a large patient population by any means, but it goes back to a little bit of what our initial thought process was when we were delivering these treatments. We were essentially taking a dose and fractionation approach that had been successful in the brain, and again delivering that within the body. So our initial experience was actually with a single 20 gray fraction, which is similar to that one which we would use with our gamma knife for brain metastases. And that led to at least decent responses, and we got complete response rates in the percentage of these patients, and again, partial response of 31%, and stable disease over time, and many more. However, what we found was that with fractionation, we could improve upon these outcomes. So now we use more of a 3 to 4 fraction approach, depending upon the location. We've treated over 2,000 lung lesions at this point. And really, I think what's different about this approach compared to that of our conventional radiation is that we've changed the pattern of spread from that of being local failure, which was certainly seen with external beam radiation therapy or even in the setting of radio frequency ablation, to now being the primary site of failure being distant. And again, this highlights some of the European data where they've looked at comparing focused radiation to that of VATS resection. And again, if you look at just the local regional control rates, surprisingly, radiation was favored over that of VATS resection. So there's some caveats with certainly that in many cases with SBRT, 50% of these patients only had a biopsy. However, we know that VATS resection will lead to upstaging of about 20% and benign disease in about 10. But regardless, I think the results of this are intriguing in that we see local regional control rates in a setting where you're not using radiation to accurately address the lymph nodes, which in comparison to what you would do with surgery, we do see improvements with local regional control. Again, this comes back to potentially utilizing and understanding the biology that goes on with radiation, and is it an immune stimulatory process? So leading to what we know versus with external beam radiation versus that of radiosurgery, within the conventional radiobiology paradigm, we talk about the R's of radiobiology with repair and resortment and repopulation and reoxygenation. And this is primarily mediated through indirect effects on the DNA through reactive oxygen species. In contrast, what do we know about radiosurgery? And this is, again, primarily delivered in 1 to 5 fractions. Are the effects the same of that which we see with external beam radiation therapy, with the effects on being on the DNA? But also we have data regarding radiosurgery in combination and the effects upon the vasculature. So now we've had data for over 10 years where we've looked in anti-apoptotic models, and we look at the growth response following radiosurgery when these tumors are not able to undergo apoptosis of their supporting vasculature, and you see a dramatic growth difference between the two systems. Or is it in combination that radiosurgery is actually more immunogenic in that we're promoting more of a increased T-cell response that can potentially go and offset some of the abscopal effects of radiation. So we certainly can use some of the current paradigms in our treatment model to study this, and I'll go over that a little bit more. We certainly can look at the different characteristics of the patients that we have and patient selection. Where are these tumors located? Are they in novel sites where we could potentially introduce biopsies, leave sites untreated initially, and then go back from a logistics standpoint and treat these later with a biopsy that would then potentially show us immune infiltration? How are we introducing and how are we now treating these more challenging sites? Can we use technologies to help offset this, such as tumors within central locations? Can we use PET-CT? Can we use PET as both a way of identifying the tumor as well as a potential identifier of patients that are at risk for failure, where we could again introduce in potentially checkpoint inhibitors that have been proved for lung cancer? And again, what side effects are we causing within terms of the chest wall or disruption of the bowel? So for central tumors, we certainly rely heavily upon PET-CT to help us identify and delineate the targets, as well as our ability to perform PET-CT scans in combination with assessments of motion. So more of a 4D PET-CT approach, which is shown here. The PET-CT data has also been interrogated through our group, where we've looked at the importance of the pretreatment PET SUV in those with less than or greater than 5, and being a predictor for those that eventually go on to have an inferior response. So with the PET-CT, we could potentially utilize this as a way of stratifying patients up front and introduce, again, either a PD-1 or a PD-L1 inhibitor in this setting and potentially improve upon that local, regional, and eventual distant control. In terms of our central lung database, we've certainly treated at this point close to 200 patients, and these are patients all with disease within 2 centimeters of the tracheobronchial axis, and we've looked at these reoccurrence patterns in the dose fractionation model in which we've utilized. Throughout the country, as dose escalation studies were conducted at the University of Indiana, they went up to doses of 66 gray and 3 fractions. Concurrent with that, we were using more of a prolonged fractionation approach where we were utilizing 48 gray and 4 fractions on non-consecutive days, and in some instances up to 50 gray and 5 fractions. Here again, you're getting a BED of over 100, where we know that there's an improvement in local control. And similar to that in which you would see with a 3-fraction approach for peripheral tumors, you see an approaching local control rate of 90%, with a decent regional and distant control. And certainly our series in combination in comparison to those throughout the world, low toxicity rates with grade 3 toxicities being less than 5%. In terms of location, I think this is really more hypothesis generating data at this point, but if you compare upper lobe to lower lobe tumors, and these were tumors that were treated with 2 different treatment platforms, either the CyberKnife technology in an earlier generation model versus the Trilogy platform where we utilize a more cone beam CT. And then we compared tumors in the upper versus the lower lobe, and again looked at local control rates. Of course, with the CyberKnife, we're using a surrogate for the tumor, and where we place fiducials in and around the tumor, and we rely upon the technology to track this. As we know from our gating studies, tumors that are in close proximity to the diaphragm certainly have a greater profile in terms of tumor management, and this relates into a decreased local control when we're treating into tumors within the lower lobe of the lung. And this, so if I go back one, again, this data was primarily showing that tumors within the lower lobe of the lung treated on a previous generation CyberKnife platform had a decreased local control compared to that of our LINAC-based platforms utilizing cone beam CT and motion management. Now, certainly this doesn't apply to the more modern units and utilizing better dose planning algorithms, but again, hypothesis generating at the least, and potentially an important topic when we move into utilizing this technology in patients that are actually operable. So could you use location within the lung to better stratify patients that would be treated with radiosurgery versus that of surgical resection? Moving out of the lung and into the head and neck, we've done a similar process where we've looked at dose and dose scheduling in terms of coming up with an optimal dose fractionation approach. Our initial series, again, started with a single fraction, and then we quickly moved on to a multi-fraction approach and conducted a dose escalation study where we went up to 25 gray and 5 fractions. And utilized this on non-consecutive days, and from 25 gray and 5 fractions we went up to 44 gray and 5 fractions as part of a phase 1 dose escalation study. We've now been able to characterize up to about 500 patients where we look at the dose and the volume relationships and ways of integrating in systemic therapy. When we compare treatment options for recurrent head and neck cancer, we have our standard options of either reirradiation, which was defined in many ways from the RTOG studies where they integrated in cisplatin and paclitaxel. And in many cases, these results of this are quite disappointing with local control and overall survival rates in around 20%. However, we see with grade 3 toxicity, it approaches nearly that of 75%. And what our goal was with SBRT was, again, provide an equivalent rate of local control and potentially achieve that with less toxicity. So in terms of our modeling of patient responses, and again, our clinical data to support that, what we found is that dose escalation does lead to improvements in local control. We've now combined that data with multiple centers throughout the world, and we've been able to characterize it better that, as you would expect, as you increase local control, you can also translate that into improvements in overall survival. And instead of, as you go up in the volume and need for treatment, which in the brain we often need to reduce dose. So as we go from tumors that are 2 centimeters in the brain to those that are over 3 centimeters, we're certainly going to a less dose. In the head and neck, we need to do the opposite. For tumors that are less than 25 cc's, reducing your dose to 8 gray and times 5 or 40 gray and 5 fractions can give you a local control rate of about 80%. However, to achieve that in tumors that are greater than 25, dose escalation is needed. So for those patients, we will treat up to 44 and now up to 50 gray and 5 fractions. We've most commonly integrated in cetuximab with this therapy, either as a loading dose and given concurrent with the first and third fractions, or excuse me, first and fourth fraction, to now delivering it also adjuvantly in combination with docetaxel. In our series, when we've looked at radiosurgery alone versus that of in combination with cetuximab, there's a dramatic improvement in overall survival. And this is kind of the crux of our now prospective series where we're integrating in additional systemic therapy. So there's a clear dose response for both local control, and that dose response translates into an improvement in overall survival. If we look at the dose response curve, it's steepest at that 35 to 45 gray range, and for tumors greater than 25 cc's, a dose of 44 to 50 gray and 5 fractions is most appropriate. In terms of local control rates, this is just showing the pre and post-treatment effects of a patient that had an inoperable tumor in and around the vasculature, and her continued complete response now close to almost 2 years after treatment. When we look at toxicity profiles and compare to that of conventional regimens, either our series or even the French data show that with the combination of cetuximab with this 5-fraction approach, the toxicity profile was much more favorable compared to that of our traditional regimens, with now seeing grade 3 complications in the 15 to 20% range versus that of 75. I mentioned that our current approach is to combine this with both cetuximab and now adjuvant docetaxel, and we're giving that for 12 weeks or 3 months following the completion of radiosurgery. We've now also integrated these treatments into active management of the pancreas. So as other institutions have moved away from radiation in its entirety and more of a chemotherapy and a systemic approach, we've continued to integrate in focal therapy for those that are properly selected. So for patients that can undergo a neoadjuvant regimen of chemotherapy where we optimize either with FOLFIRINOX or gemcitabine-based regimens, we then will restage and treat these patients with localized disease with radiosurgery. We will most commonly use a 36 gray and 3 fractions, and it really, this is modeled anywhere from 24 gray and a single fraction, which was used at Stanford, to now 25 gray and 5 fractions, which is used primarily at Hopkins. The difference in these 3 and 5 fraction regimens is really how you look at your dose fall off. I think I have one picture here that kind of shows a typical treatment plan. So Steve Burton is our primary radio SBRT planner for pancreatic treatments. The dose fall off is key. You can certainly center a high dose within the pancreas itself, but you must watch the dose fall off towards the bowel. And what he's aiming in his 36 gray and 3 fraction regimens is to have the 50% isodose line follow that bowel contour, so that really your dose and max dose, at least in a 3-course regimen, is not much more than 6 to 6.5 gray per fraction to the bowel. And in this setting, we've seen a very low rate of bowel toxicity compared to that when we were doing more of a single fraction approach. And the 5-fraction regimens that are providing more of a peripheral dose, they're actually creating more of an integrated boost where their primary target is reaching that of a similar equivalent dose to that of the 36 gray and 3 regimen, and they're putting their prescription isodose just at the bowel. In terms of the first 12 patients that we looked at, at least in the neoadjuvant setting, so these patients have now gone on to get the local therapy and then follow that with additional surgical resection. And we look at the response rates. It's much easier to read. At the bottom, 25% complete pathological response, and an additional 25% with less than 10% viable tumor. Then what this provides us, and that in which I'm most excited, is that this is an opportune time to actually study the radiobiology of radiosurgery or SBRT. And that we're now, for the first time, able to really achieve tissue that we can then take to our laboratories and start understanding the biology of this approach. Okay. So again, this is our neoadjuvant approach in our prospective study, utilizing gemcitabine and capecitabine, as well as surgical resection and the translational studies that relate to that. We're now coordinating a multi-center study where we look at SBRT for prostate, where we follow quality of life and outcomes quite closely in this model. So this trial, I believe, is up and running through multiple sites through the US now, as well as international sites. And similar to that of other institutions, we're delivering 36.25 gray to the prostate with margin, while the integrated boost approach to the prostate itself of 40 gray and 5 fractions. We do create a cold core down the center of the prostate, which you can kind of see on the lower right, where that represents the urethra. So we're keeping the point dose to the urethra quite low, and again to reduce urinary toxicity, and certainly cancer cells within the center portion in and around the urethra is quite rare. We've been able to at least model out the initial PSA trends in these patients. And similar to that of other reported series, and one which was reported by the Stanford group most recently, you see a dramatic decrease in a portion of these patients following radiosurgery. Similar to that of brachytherapy, within the first 3 months, there's a dramatic decrease, whereas another cohort will have more of a slow response in their PSA. Again, teasing out this is now the focus of our laboratory efforts and trying to delineate the differences in these responders. To shift gears a little bit towards tumor metastatic disease. So we know that many disease sites now have a predetermined profile in terms of their metastatic pattern, and this can be predicted by different markers within the blood, and to demonstrate that either tumors will have the predisposition to form tumors within the lung or bone or liver. And it raises the concept of, can you again now treat oligometastatic disease with local therapy and improve upon the outcomes in these patients? There's certainly a surgical data set to support this, and we now have up to 10, 15 years of data that show survival rates with those with oligometastatic disease resulting from colorectal cancer with involvement of the liver, for instance, where 10-year survival approaches that of 30%. And can we approach these patients in a similar way with stereotactic modalities? We've conducted a phase 2 study, as well as have a liver metastases phase 1 where we're performing dose escalation. We started with 50 gray and 5 fractions, and that is now up to 12 gray per fraction. We have a site, 2 oligometastatic studies, one for patients at initial presentation where their primary is managed with the traditional treatment modalities for that primary site, with those with 5 or fewer metastases at outside locations treated with radiosurgery, and then those with 5 or fewer reoccurrences at the time of metastatic presentation that we'll then deliver focused therapy to. The majority of these patients are treated with a 5 fraction approach, and we're now enrolling patients from Ireland and throughout the world on this trial. It's now over-accrued our initial plan of 100 patients, and I think we're upwards of 125. This was just the initial report on the first quarter of these patients, and again showed that 25% were alive with no evidence of disease at the time that the study was conducted, with local control rates at that of the target site of around 90%. And again, there's data throughout multiple institutions, our own as well as that from Rochester with Dr. Milano's group, that again, all of these show essentially the same, with 90% local control rates and identifying about a quarter that could potentially respond and have long-term disease control. We're trying to identify these patients a little bit better. We're now performing assays throughout the courses of these treatments, taking blood samples from the before and after treatment. So while the patient's on the treatment table, we'll pull PBMCs both before and after and isolate and look for phosphorylation of ATM within the phosphorylated blood. So just within the circulation pattern through either the lung or even the abdomen, we can detect phosphorylation signals even within these treatments that are just within seconds, and potentially utilize this to help identify those that are going to respond to the therapies versus those who will have a less favorable response. our hope is that we can then use this in combination with novel therapies and identify patients that could then be integrated in with systemic approaches where we integrate in checkpoint inhibitors. We're currently working with the RTOG as well as industry-sponsored trials where we will use focused radiation in sequence and try to tease out some of the dose fractionation relationships with checkpoint inhibitors, as well as the need for looking at different volumes and treatment and how we potentially sequence these therapies.
3 minutes.
Okay. So just to summarize, perfect. So in terms of our opportunities, we certainly will deliver radiation in the definitive setting for those with oligometastatic disease. And our hope is that we will now begin to transform and translate how we're treating these patients, even that in the abscopal effect. So certainly I think that there's a benefit in terms of that there's minimal toxicity with a superb local control. It's minimally invasive, and if we record and continue to monitor patients' quality of life throughout this, we will gain upon improvements in our patients' lives. Okay, any questions?
Thank you very much. You offer us a very broad landscape of studies and studies that could generate hypotheses, and that is very, very, very worthwhile. We have time for one question because I want to leave time for the discussion at the end, because if we go long at the end, we will have no time for discussion. So I try to stick to the time. I apologize for forcing the speaker to stick to the time, but we need to be there. We have time for one question, if it's there. I don't know. And okay, and what is no, I want to say you something, because there is an issue always, movement. So what do you consider there is the tumor site where you have to deal with more complex technical issues, taking into consideration the movement of your target?
Yeah, so I think anything within the abdomen. So the bowel, to me, is the most, outside of the spinal cord, is certainly the most sensitive of the structures throughout the body. So as we look at even adrenal tumors or the pancreatic tumors that have a significant amount of motion in close proximity to the bowel, that's where I'm most concerned in terms of reducing toxicities, and that's where we'll reduce our dose as it falls off towards the bowel and maintain that constraint.
Great, thank you. So now we move to the next speaker. I switch in Italian because Professor
Alessio Morganti. He will summarize, he will merge the two lectures in one. So it will last about 30 minutes. Okay, Professor Morganti, he works in Bologna. Thank you, Piercarlo. Thank you, Vincenzo. The title is a little bit exaggerated, like the pillars. Well, I don't like pillars so much. So, Alessio, please sit down. Okay, prefers to stand. Can you hear me? Okay. No. We don't have the audio. Sì, sì.
No, io non si sente.
I'm not very good at talking while sitting. I will try. Because honestly, I wanted to use the laser. The problem is that I should move a little bit here and there. Let's see how it goes. So the clinical viewpoint My presentation is less serious than the previous ones. I'll give you my viewpoint. I'll tell you the story of when I was young. Since I were the youngest one, I was the unlucky one, so I followed the pancreas tumors, and I treated with the tools we had at the moment with the radiotherapy and flora. Those patients were very sick. We had a quite good local control, but they had a lot of toxicity, acute toxicity with fluorine. Then we used gengitabine. It was worse. Toxicity worsened. There were patients coming back a few weeks later, 2 weeks later, and they lost about 10 kilos. They had a lot of disturbances, nausea, and side effects. A few years later, we had the chance to start with the stereotactic therapy. And I started with a few people sitting here today. At that point, what we saw is this, or at least that was my feeling. Suddenly, our therapeutic door was wide open. With low doses, patients responded, they were better, and toxicity was almost equal to 0. 2-3 weeks later, I saw them again. I was very worried, but the patients were okay. So that was my feeling with the stereotactic therapy. It seemed that the tumor becomes more sensitive and the organs more sensitive. So the clinician wonders why SBRT improves the therapeutic interval. We could find some potential explanation. Maybe there's an explanation in the classic radiotherapy, or maybe in the LQ model, maybe new models. Or let's delete all the DNA damage and look at new biological aspects. The very basic principles. We start from damage repair, the first air. Does it explain anything? The repair tells us that the tissue grow slowly, they die slowly, late. They have a late toxicity, and the cells have the time to repair the damage, and they repair the sublethal damage. So if we give a small dose of per fraction, we have a repair. If we give, if we do a big fraction, there's no repair. So late damage depend on fractioning. These are late responders, and if fractioning increases, toxicity worsens. So repair tells us that stereotactic should give us a worse toxicity. Then we have different phases of the cellular cycle, then different organization of the DNA. Imagine that in certain phases we have the chromosome. If we give a radiation, we give a lot of damage. This damage is not repairable. Instead, there are some phases with a single reparation ray. I mean, we can repair the damage. Here, these are the survival curves. If we give more applications, we have more chances to target the cell in the sensitive cycle. So maybe resortment should give us a worse result. Maybe the repair is not working. The tumor is oxygenated only at the external site. It becomes smaller, but it's radio-resistant. We wait for 24 hours, and we give another one. So we wait the 24 hours for the tumor to be oxygenated or non-oxygenated. So from this viewpoint, stereotactic therapy shouldn't work. So what should we do now? Repopulation. The tumor proliferates rapidly, cells die rapidly. So if we give a small or big application, we are not repairing the damage. If they grow rapidly, the cells repopulate. And the important thing is the duration of the treatment. If the treatment is short, the tumor is better treated. So stereotactic therapy here doesn't work. Is that true? So and so. You have seen this picture many times. So there is a modest repopulation during the treatment. It accelerates after 28 days. So why the 30-day treatment is better than 40 days, but 5 or 25 days is more or less the same. So what is the advantage of stereotactic therapy? Or why does it work so well? So no classical therapy. ALCO model tells us that viable, V stands for viable cells. So half of them die because it's targeted repeatedly. So if I target these cells, what happens? The 4 photons kill 4 cells. The other 4 photons damage the other 4 cells that don't work, that don't die. So I have 2 different survival curves. If I give a double dose, what happens to the photons? So 4 photons go on the left, 4 go on the light. The other one, some cells were already damaged, so they will die. Others won't die. So we have 25%. The line is still straight. The other line starts moving. So the survival rate is maybe, the survival curve is maybe the sum of the other 2 curves. Reality is that tumors are not actually divided 50%, 50-50. So the curves will be a little bit more this, a little bit more that. So at the end, this is the tumor curve and healthy tissues curve from the late toxicity viewpoint. If I give another dose for fraction, I have a less effect on the tumor, more effect on the healthy tissue. So the IQ model is not the answer. Let's go to other radiobiological models. Maybe the IQ model works from 1 to 8 rays. So we had a big discussion. The IQ is too curved. we'd like to have something more credible, more believable. This model is not good, it's too curved. We have a lot of debate, curved or straight, like Kate Moss, like she had two curved legs. Maybe we like to have more straight things, legs like that. So we want, sorry, it's too so fast. So we wanted to have a more straight model, the 3-parameter model, or the universal survival curve with a more straight curve. But somebody says that that kind of model doesn't work. So we know that alpha beta tumor is 10. Maybe it's not true, it's less. For lung, maybe it's 20, 25. If we change the value, alpha beta value, we have the other curve, more complex models. So maybe we don't really need new models. We have an article talking about curves or straight lines. He says basically that the LQ model is alive. We don't have to throw it away. We should continue using it. So it depends on the right parameters. So do we need new models? The LQ model is appropriate, even with high doses. The LQ model is not appropriate with high doses, though there's not so much agreement in literature. What else? We have other experimental data on animals showing, like in these lines, the points are experimental data, animal models, spine, bowel, other tissues, they fit wonderfully. Points go on the lines, A5, A15, A25 per fraction. So this LQ model doesn't work. That's to be demonstrated. So maybe we need what new biology, new everything. The LQ model was interesting, but is controversial, like governments. So somebody says maybe this model is too conservative. Actually, the effect is much stronger. But this model, with this model and high doses, give cellular death, but the vessel starts to be damaged. If we damage the vessel, cells die. So what we actually see in the survival curve is the sum of this and that. So let's forget LQ model again. Vascularization is important. The effect on vascularization is important. This was published in 2005. Damage on the tumor depends on the damage on the microcirculation. But the effect is higher with the high doses, because if we fraction, there's new mechanism because of hypoxia. We produce new kind of damages, so we have a less effect.
Così.
And this summarizes to the vascular damage because those experiments have never been confirmed by other experiments, and the majority of experiments demonstrate that damage to the vessels is very limited any dose we give, any dose per fraction we give. So this concept must be demonstrated. And today we will talk also about the immunological aspect. We have a tumor cell. I treat it with radiations and antigens free, and then we have dendritic cells and lymphocytes and T cells are activated. And so the effect multiplies. And finally, we've learned why SBRT works. This is, I think it's a very nice picture. I hope you can see it. On the left, you see this cell exploding. That's this SBRT arriving. We have dozens of pieces and antigens. And explanation of why SBRT works. It's probably these immunological aspects. But among the most interesting experiments that we've conducted on animals, which demonstrated irradiation transforms macrophages in very good macrophages and so on. So there is a reactivation of the vascularization, and they promote immunotherapy. This has been demonstrated, but only at low doses. So this has been demonstrated repeatedly at low doses per fractions. And what about the opposite? So the clinician's perspective is that I don't see why SBRT is working. And then we also talk about the abscopal effect produced by the SBRT. High doses produce the abscopal effect. These are the tumor growth delay curves if we irradiate the tumor. And this is what happens to the metastasis that is not irradiated. You can see here that these empty symbols indicate when immunotherapy is associated with radiation therapy. If you can see, this is low, and so radiation therapy is working on the tumor, but also on the metastasis that was not irradiated. So we do have a abscopal effect, but this is the effect is less evident when the fraction is single, and it's more evident when we have a fractioned treatment. So are we sure that the abscopal effect occurs when we use high doses? Apparently no. Moving towards the conclusion, you can see there are several theories which have not been confirmed, but let's play a little bit. I'll invent some theories. Do you allow me? Can I have an extra 2 minutes? So we know that EGFR is activated and it produces a series of effects which are very bad for the tumor cells. Especially we have an increase in the proliferation and a reduction in apoptosis and the effect of the therapy. The EGFR is hyperexpressed in epithelial tumors, but the mass occurs because radiation therapy causes damage to the tumor cells, but it also activates Rx. So we have a radioprotective effect. It sounds weird, but that's the reason why we have started using things like these with some kind of success, just to interrupt this. And this happens when the cell is damaged. But if I use ablative radiotherapy, what happens? Can it block this vicious circle? Maybe not. This is a second theory. We look at the microenvironment. We have the cell, we have the vessels, we have the matrix. We know we have apoptosis, so we select specific cells, and slowly cells become resistant to apoptosis, and there is a regression and invasion, and then the metastasis. It's a little bit more complex because hypoxia causes AKT, HIF, MAP, VEGF, I don't understand what HIF is for. Maybe it stimulates the other two. But what I understood is that these are things that make sense, that they make the extracellular matrix more fluid, and so oxygen goes through, but also the tumoral cells. So this causes worsening, whereas the VEGF does something else. So we have hypoxia in the vessels, tumors. It produces a lot of endothelial cells, which consume a lot of oxygen. So hypoxia worsens the other factors. So fortunately, we have radiations which arrive and cause damage to the cell. But unfortunately, radiations activate the same mechanism. So an increase in these factors, and therefore there is an radio-induced invasion. We have metastases, which are radio-induced. We have angiogenesis, which is also radio-induced. And so radiation therapy worsens hypoxia. So this is weird. But simultaneously, hypoxia increases. So theory number 2, this happens if the cell is damaged. What if I do ablation therapy, if I kill cells immediately? Will this block the whole system, maybe? Theory number 3, maybe both are true. So nothing is working. For me, I'm a clinician. Nothing explains to me why SBRT works. And this is the final part of my discussion, but I will try to explain it. Just follow me for a few seconds. And this is just a simple explanation for a simple person like me. You see the green symbols? That's the 3D radiation therapy. Blue symbols is fractionated treatment, and the other ones are it's the CRT. You can see the tumor control versus the BED. So we have BED. We can see the probability of control. If you can see a clear correlation between BED and probability of control. And on this line, we have both 3D, single fraction, and stereotactic therapy treatment. There is no curves, no steps. They are all on the same line. This means they are the same thing. So SBRT has nothing magical or special. The only special thing is that we're using a higher BED, which we cannot use with the 3D. So we can treat 90% or 100% of patients locally. We can only do it with SBRT only because these BED values cannot be used with 3D. So this is the only idea that I have. So talking about the next presentation, we do have the same response. They're all here on the same curve, same efficacy, that they don't depend each other. We'll decide, of course, based on tolerance of surrounding organs. So my feeling was wrong. Nothing magical happened to the blue curve. It didn't move to the left. The only thing that happened is that thanks to technologies, that the curve moved to the right. So we've used higher doses. This is the curve that we have used. We're here at 100% control, thanks to the new dose that we're using and that we've been using thanks to a reduction in the toxicity. So why SBRT improves the therapeutic window? Just because it reduces toxicity, and this is because we are better distributing the dose, and we can have a higher bed as well. Also, thank you very much.
Abbiamo 3 minuti.
So 3 minutes for some questions. Thank you, Alessio. That was really fascinating. Any question? So I have 3 minutes for questions. Why? You're Sadiq. Do you know them? No, it's not true. I love you. Okay. I ask you a question. It's very simple. As you have a very natural way of presenting your topic, in your final curve about the bed have already LQ model behind them. So if the model is okay, or maybe you were using another model to see the trend of the doses. So over there, you are saying that you don't move from that principle. Yes, there was an extra slide that I removed. What I say, LQ model, no. Actually, that was LQ model, yes, because it fitted with that curve and the other results. If you read literature saying there is a relationship with a dose significant in the lung in hepatocarcinoma, so the bed is always calculated with the LQ model. Piercarlo. So if we change the alpha and beta, sorry, the audio is not in the headset. So maybe our technology allowed us to be more precise. We can know where the target organ is, where our target is. But basically, we can be more precise about defining the area to target. Yeah, I agree. For some tumors, alpha, beta is endless, or it has very high value. Strigari. Instead, we talk about the medical physicists on other viewpoints. I like to start with these aspects. SRS constitute a potpourri of technologies and techniques, but the focus is that radiosurgery delivers a powerful dose in oligofractions. It starts with many experiences that have been reported in literature. It used to treat many types of brain tumors. Hallmarks of RS is high precision, high accuracy, rapid fall-off of doses that minimizes a normal tissues dose. Can I ask you? Maybe that is the wrong presentation. Thank you.
Grazie. E quindi sostanzialmente diciamo che questa tecnologia viene somministrata con varie modalità.
So this technology is administered with different techniques, and it determines different distribution of doses, accuracy, and different conformation. Everything is based on two crucial points: high precision, high accuracy. If we want to apply the LQ model to fraction or stereotactic regimen, if we expect a high survival of the tumor, we could also save healthy surrounding tissues, so we can actually reduce the damages. So we should review the concept of the 4 R's. And the only thing we can do is trying to model these kind of results. Physicists, when they say points like this, they attempt to fit them because they want to understand how to behave if we don't have experimental data, if that fractioning scheme is reliable. If we have a 3D distribution and complications and outcome linked to the local control, we create this kind of fit. In this case, it's much simpler. And the second case is much more complicated. We use two kinds of models. A phenomenal model with an empirical approach. And then we apply curves, keeping into account what could happen in intermediate situations. Or we can use a mechanicistic approach. So we start from in vitro, in vivo studies, and we can model basic effects and have to be more secure with new scenarios. All the models should have both the characteristics, so simple and describe what happens from the microscopical and macroscopical viewpoint. A tumor control probability depends on the initial number of cells on the ratio of cell sterilization. So if the technique is good to do the sterilization of the tumor cells, we can take information to determine the number of and type of cells. So survival curve derives from the fractioning schemes. As to toxicity, we start from a very simple situation: uniform radiation on a given organ. We take alpha over beta study deriving from other studies. We need to compare data from other fractioning schemes. Then we need, in order to show how the model is simple, at least 2 other parameters, D50 and slope per D50 parameters. This way we can explain the experimental data. From a mechanicistic viewpoint, we assume that if we have a dishomogeneous dose, we can reduce the distribution of this kind of dose into a uniform dosage. This helps us because, with simple parameters, we can describe the effects of organs with mixed architecture using 2-3 parameters. Also, the Quantec supports us because we have two types of model, a phenomenological, Lyman and Kutcher, and the second is the relative seriality Morgan applied to organs, the interested organs. With these kind of models, we can introduce any kind of parameter that can explain the effect on the patient. So those distributions, clinical risk factors, any concomitant treatment, and any other factor useful to correct the approach we are applying. And we can also introduce other concomitant treatment. This slide shows the effect of necrosis on the encephalon when we treat with the stereotactic therapy. This derives from Quantec as well. Here we see how the toxicity increases if we exceed the volume to treat the target, so over 12 gray, if it becomes 10 or more centimeters. Also in this case, we describe the necrosis according to the bed. Another example is radiation-induced optic neuropathy. Here we know why the models are very important, because experimental data are available if doses are low or for a single session. So in the intermediate phase that we use more often for hypofractionated treatment, we are relying on other models. We're trying to interpret the results of the treatment after applying some models. For healthy tissue, we are very confident that LQ model is very well represented up to 20-25 gray. So for healthy tissue, it has just a few parameters. It's not very much test. And up to 10 grays per fraction, it can be used. Above 18 grays, we have uncertainties. If we look at what happens according to other experimental data, the famous LQ model on the cellular culture treated with more than 6 grays shows a trend, a linear trend, beyond a certain threshold. So we must say that different types of cells have a different alpha and beta. So if the dose exceeds the alpha over beta value, the curve, the response curve, becomes linear. So this is a first model. The second model that we proposed is the universal survival curve. This model, if we had to rely on the other two models, in that case, this approach can be easily obtained. So if we increase the alpha over beta value, we can show and we can explain all the experimental data. But on this work, on this study shows that if we use the LQ model, we have alpha over beta 16 versus a smaller one if we use the LQ model. But if we have only low doses data, the LQ model overestimates the damage. So this explains that if the experimental data cover all the range, interested range, we can use the LQ model and the data fit. If we have to extract some data for those intervals that we don't know, we can compare different models. This is a comparison recently published on study on about 3,000 patients with lung and brain metastases. In this case, the study shows that we don't have statistical modalities to say that the data with a low LQ model or LQL, they suggest different results. So if we have equivalent models, we prefer the simpler model. Here instead, we see that if we look at the subset only, for this treatment, the LQ model, with a small adjustment, keeping into account the different type of cells within the target tissue. Here it indicates that the multi-fraction treatment would be better than the single fraction treatment. Here we want to focus on 2 points. Sometimes this kind of study becomes very complex because authors talk about what happens in the peripheral area. Actually, the dosage is important to read the data. This way, we should reduce a single histogram and improve the prediction data. In general, besides the LQ model, we could evaluate other models like the survival curve.
Sarebbe più cautelativo nei confronti del paziente.
Another additional item with reference to all the other arguments which have been raised until now. Just a couple of points here. The first being is to destroy the cells. We know we need low levels. If we need to destroy toxic ones, we need higher doses. If the doses are over 10 gray, we start having a damage at high doses, which produces secondary cell killing, which are both benefits and detrimental, as we will see. In terms of what is becoming more and more interesting on an international level, is the fact that we are able to imagine a similar treatment, SBRT, with a treatment with which we are able to start a series of phenomena, to start up these phenomena with different players and markers, which basically, by means of an appropriate action on the immune system, can sterilize lesions which are located far away from the target. And from a physicist's point of view, it's important because you understand that we are limited by the fact that until now radiotherapy has been considered like a local regional therapy. If the target is exactly identified and we know exactly that the number of cells are enough for us to see it, we can target this volume. If this is not so, if this is not feasible, we are not able to obtain the outcome which we desire. So going back to this study by Duan and his group, this basically tells us that if we use only fractionated treatments with low doses, the immune system makes so that this abscopal effect is implemented when we use CTLA4 antibody. Other studies instead, such as this one, suggest that by using only radiotherapy and not stimulating the immune system, one of which is this one by Camphausen, we have the other effect with high doses and hyperfractionation. We see that the lesion or a healthy tissue, and we are able to sterilize the target, contralateral target. So no dose from radiotherapy. So we did a similar study in which basically we reviewed tumors of the colon, and we inoculated on the sides of the mouse, and in both lesions, notwithstanding the fact that they were P53 or mutated, and we had players, but the abscopal response contralaterally was only detected when the well type was in the contralateral position, and we saw that in a lung tumor. And I will skip this. I'll just leave it for you for future reference to take away. These studies could open new scenarios in terms of abscopal effects related to this type of treatment. Just to mention one thing, when we have the good data, good count of abscopal is when we have a dose rate of 23 over the cells. In others, we have much lower dose rate. So the dose rate is effectively an activator of this phenomenon. Of course, radiosurgery, we are on the clinical side here, and we have started to combine different agents in order to improve, enhance the serotaxia response. What I wanted to highlight here is that when we have better controls and using one agent versus another, we need to collect new data which are we need to collect other data related to possible serious side effects related to the combined effect of the two agents. In conclusion, the vascular damage must be taken into account when we have these hyperfractionation regimens. Other pillars, such as redistribution and repopulation, are no more. In order to better explain the biological effects, we need to reanalyze new data which are arriving or being produced lately, and better improving the prediction of these models. Thank you for your attention.
Thank you for this further integration with a couple of models that integrated Dr. Morganti's presentation. I'd like to invite Professor Genovesi, Director of Oncology Radiotherapy in Chieti. So terminology, the identification of volumes. Thank you. Good morning, everybody. Thank you, Piercarlo.
Certamente la crescita vertiginosa della tecnologia.
Of course, the rapid growth of radiotherapeutic techniques and SBRS put us at risk, a risk to be confused about the terminology, about the language, that could be dangerous when we evaluate the effects on the studies that we are conducting in order to speak the same language. Also, the actors within this technological evolution are multiple people with whom we collaborate every day. So it's important to make an effort, a mutual effort to speak the same language, because the pillars and radiobiological modeling is crucial. They're crucial. New techniques, allowing us saving healthy tissues and obtaining excellent results. But if we don't speak the same language, as we said, the result could be compromised with an inter-observer variability, as we are observing, with all the risks, with all the organs at risk. As you see, the variability can be transmitted in the stereotactic environment, with the consequence that the DVH could become negative. So volume definition must be accurate, methodologically correct, with a very small variability. So what are the goals, what are the aims of a common terminology? For sure, to get to an agreement, multidisciplinary agreement on a terminology to improve the communication, to facilitate analysis, comparison among studies and meta-analysis that we find in literature. We need a language that is technologically independent, so radiosurgery, linear accelerators, stereotactic therapy, so independent from technology. It has to be compatible with the principles of ICR U62 and ICUR U83 documents. And while we're waiting, of course, the new ICRU prescribing and describing the new subjects. What is there in the new literature now as to volume terminology? As Vincenzo was saying before, I wouldn't talk about lexical semantics, but I would focus on methodological recommendation. So language, lexicology, that the International Lexel Gamma Knife Society standardized a series of terms concerning GTV, which is equal in brain lesions, replaces the target volume. The volume that is delivered to the organs at risk. As to the Many terms are changing. This concerns the target, and you see as generally GTV is equal to CTV and so on. So literature gives us methodological recommendations, and the same society, the same association gives us a strong recommendation to work on imaging and imaging techniques. If we talk about multidisciplinarity, multidisciplinary work, and how the topic should be discussed from different viewpoints, it means that it's important to talk with the different specialties to go into the mechanism, such as if we talk about magnetic resonance volume, what it means, single contrast, double contrast, what they... It's also important to know the detail of the scanner types, the field sequences T1, T2, and the co-recording system.
Okay.
This also introduced a very critical topic, because co-registration must be performed with a clear, defined methodology. The other recommendation is obviously to go and express our volumes in CC or in percentage, both in the planning phase, but also during the clinical assessment in the follow-up versus diameter calculation. Another recommendation regards organs at risk, which obviously not just imaging techniques per se and the manipulation of the MRR and brain lesions, but also organs at risks and the possibility of having a good number of slides to contour the cochlea with a whole organ delineation, because some of the organs have different types of sensitivity. The optical pathways as separated structures, hypothalamus and pituitary stalk separated, pituitary gland and spinal cord, again with a necessary length beneath, underneath and above the target, with 8 to 12 gray. So, in terms of the trunk, it is important to have a MRI, a multiplanar approach to the MRI for the trunk in terms of the optical pathways, as we saw before, and in terms of the chiasma, optical chiasma, in terms of the hypothalamus. So you understand there's a lot to be understood and interpreted to have a good MRI. And this gives us a possibility with the learning curve, which is considerable, with our neuroradiologists to see optical nerves and also a very critical organ, such as the cochlea in this specific case. For spinal lesions, the literature seems to focus on studies such as this, which is the International Spine Radiosurgery Consortium, which has delivered these guidelines, a consensus, which delivers a target volume definition in spinal stereotactic radiosurgery. This classification by Weisstein, Vogliani, and Raggini, which basically divides this into 6 parts, namely the soma, the left peduncle, the transversal axis with the lamina, the spinal process, the right transversal process, and the right peduncle. 7 radiotherapists and 3 radiosurgeons have concerned 10 cases which were emblematic for lesions on the spinal cord, and they managed to reach a consensus represented in this slide in orange for the 10 types of key cases selected. But the most important thing on these lesions that we were able to receive indications in terms of their behavior. In other words, in case of LGTB, CTB, GTB involvement, how to define the CTB, include the entire vertebral body and the ipsilateral pedicle transference process. So for HCTB, what the description must be with reference to the GTB. So this allows us to reach these guidelines in terms of contouring GTB, CTB, and PTB, which I feel can be important in the clinical practice, in our everyday practice, and this can and should be used. In this type of lesions, this is also important. This is the first report which defines a target volume for spinal radiosurgery. Very briefly, the SBR, again, because we have in the room several experts. So very briefly, the critical issue of the movement. We've spoken about brain lesions in which, with no internal margin, no internal target volume. What I want to say here is that the method is obviously important when we manipulate an MRI or co-registration with MRI algorithms for co-registration and also interpreting the imaging. What is important in the body, specifically for lung and superior abdominal lesions, is the movement of the organ. So this also goes for the image fusion with the PET-CT, which must follow a specific pathway in terms of method. It's important to implement and have a method flowchart telling us what to do if we are inside a specific respiratory rate or if we overcome the maximum threshold, because you can have multiple situations. So this is just to bear in mind what the lung lesions and the superior abdominal lesions, and to have an approach and a method that can be continuous and consistent and correct. Like I said, this should be done with reference to the ICRU 23 report mentioning SBRT for small photo beams. Thank you.
Siamo perfettamente in orario, abbiamo quindi 3 minuti per qualche domanda, se ce ne fossero. Chiaramente ha fatto una ampia scansione dei vari passaggi per una stereotassi e per una fusione. Chiaramente, Mimmo, c'è all'orizzonte il discorso del famoso dose painting. Nella stereotassi è meno forse presente, però c'è questo capitolo da tematizzare. Ci sono raccomandazioni da seguire in merito al al poter tener conto del SUV diverso che noi otteniamo dalle immagini di PET o la diffusione o immagini di necrosi? Hai evidenza che ci sono delle raccomandazioni o è ancora tutta ricerca?
Che ci siano dei...
There are certainly works on great data numbers which can allow us to give us recommendations which I believe are present. No. There are many, many institutional experiences which give us a large, comprehensive picture of data, but that need to be collected in a more scientifically rigorous scope of application, which can then be implemented in the clinical practice as a recommendation, because we have a lot of data, but this data is by no means definitive. Well, thank you. I would like to ask Professor Gambacorta to give us her experience, clinical experience, and for concomitant boost in SRR. In the meantime, I would like to ask Piercarlo to join me here, because Professor Gambacorti will need to meet, report to the management, and she couldn't go, so she asked me to go, and I'm forced to go to this meeting. And so she is here, and I will go in her place so she can be here and deliver her important speech. And I would like to ask Piercarlo to step up and moderate in my place. I'll see you at 2:30. But before you leave, I'm impressed by that writing, 1831. Thank you very much. There's a very good replacement, and I'm grateful for him to go in my place. Before we leave the room for our lunch, I would like to bring you back on actual facts, and I would like to thank Piercarlo, which has given me this very difficult task, which is to talk about clinical experience. And you know, we have very different clinical experience, but nevertheless, he asked me to focus my presentation on the concomitant boost in SRS. Before I start with my presentation, I saw try to understand what concomitant boost is. And I have experience from a rectum approach, and it's administration of an additional dose of gross tumor after the standard dose, and not simultaneous administration in terms of CTV and GTV. As Dr. Morgante says, uses at least one of the 4 hours, and usually from the 3rd week after the day 28, when the repopulation starts. And a common feature with SRRs is that it decreases OTT. What does stereotaxy do? Probably, as Professor Morgante says, all fractionations are on the same curve. So the rationale of doing a stereotaxy with a concomitant boost is to use all the radiotherapy effects in order to control or heal the pathology. We have a lot of literature on SRR, RS, but we have a very limited literature on the concomitant boost in radiosurgery, stereotactic radiosurgery. So I went to see the review of the literature, there are many experiences which you will see which are up to 2006 or 2010. And this has to do with the technique. We have acquired the MRT. We have maybe we don't need to use all those technical approach and immobilization schemes or to find the stereotaxy approach. But these are indeed interesting works. This in particular was done by Cardinale. There's a radiotherapy on the encephalon, on the pre-op disease with the sudden fractionation. And then this is associated, thanks to the repopulation effect in the last effects and last weeks of the treatment, a concomitant boost of SRS, which with high doses, which go for 7 grays per fraction, lowered to 5 when the volume was slightly larger. In this case, they use lifosfamide, but they noticed that by increasing the dose, the median survival rate was basically the same. And therefore, surgery and radiotherapy reaches 12.5 months of median survival. This is a study that we did. This is an experience which is slightly more complex, maybe because Italians are more complex, and we try to foresee any possible variation. Here we have 3 radiation volumes, CTV 1, 2, and 3. We use a stereotaxy technique, both concomitant, both in sequence, also bearing in mind and always bearing in mind the volume of the lesions below 6 centimeters or over 6 centimeters. And we use a stereotaxy that takes into account the system of stereotaxy coordinates. One of the pillars is no more, because there's no hypofractionation, but there is an hypofractionation using lower doses, which are based on the low late toxicity. This study demonstrated a median survival which is higher, and authors are honest, because when they confronted with the other study, maybe this is nothing to do with the radiotherapy doses, but instead with the fact that we're using in concomitant effect of the angiopatina. What's new in this study? These studies date back to 2010, but refers to patients who were enrolled up to 2008, 8 years ago. But this takes into account that technology does not force us to use all these technical approach, and we are able today to do boost over boost. This is an radiobiology advantage, but also a practical advantage in terms of time, of using the same scent and the same immobilization scheme. These are all the techniques and advantages. And so in 2010, again, this is a study by Morganti of dose escalation using this new technology in the primitive encephalon tumor. Again, it's a dose escalation study in which the primitive dose goes up to 45 grays, and uses a hypofractionation, which is moderate, widening the indication and the term of the stereotaxia per se. There was no DLT in this study, so I can easily reach 65 grays, some acute toxic effect, which brought interrupting one treatment but not de-escalating the dose. So, in other words, in the encephalon, the concomitant boost with this SRS, this is no longer done, but we have translated the stereotaxy, enlarging and widening the scope of the term to modulated intensity. The pancreas is another model in which I study a pathology, a disease when there's a high death rate, but unfortunately we must say the researcher has immediate results. So cynically, I must say that this is cynically an advantage, and we can. This is highly lethal. So moving from the fact that the local recurrence is one of the main features and a major component of the disease progression, up to 35% for these patients. And also bearing in mind the low survival rate of these patients, it's a good field in which to experiment and test the stereotaxy, because you give high doses on the tumors which can resist the therapy. It's brief, and this allows us to support the medical oncologists who issue the chemotherapy, but we can also help the patient, and we give him or her a better quality of life for his limited life expectation. We have many experiences with the pancreas. They're slightly different. I think that the first studies started with a dose escalation up to 25 gray, and then there are several types of doses with very good local control rates, which is just 1 year, but these patients unfortunately do not survive longer. So they're good control rates, local control rates. These patients use with no progression of the local disease. The problem is that the pancreas is put in a very uncomfortable place, and it is surrounded by organs which are highly radiosensitive, and it's extremely difficult to contour the pancreas. And we have seen Professor Genovese's speaker, so it's extremely challenging to find the challenging and time-consuming, also determining the organs at risk. Just one example of toxicity. The head of the pancreas is surrounded by the duodenum. So when we issue these radiations, we need to bear in mind the duodenal toxicity, which is manifested up to 30% of patients. And this is a very serious toxicity because it gives you bleeding, stenosis, ulceration in a patient where we want to improve the quality of life. If we generate this kind of toxicity on 1 out of 3 patients, this is an issue to certainly bear in mind. This study is not a clinical, but a dosimetric study. Now, I picked this because I liked the clinical rationale of this work, this study, which is typical of this team led by Professor Morganti. I liked the introduction very much, what they say. They say that the pancreas tumor, locally advanced, can heal only if we resect it. If we do not do a resection, we can improve the local control and at least reduce the symptoms. But we need to be careful with the duodenal toxicity. What did they do? They did a concomitant boost in serial in SRS. So they divided these in 3. First of all, they defined the PTV of the vessel, because this is the tumor that infiltrates the vessel, and the PTV of duodenum. because this gives you the toxicity in terms of limitation of the dose. And then they obtained the PTV of the tumor. And they gave 3 different doses to these 3 different PTV. 45 gray, 45 grays in 5 fractions, which is roughly 74 gray in total, which must detach the disease from the vessel and is not detached off the duodenum. If it responds on the vessel, I can treat the patient. But if it does not respond on the vessel, this disease can be resected, because if we do EQD is 40 gray, and 40 gray can be palliative. And this is a study on the doses, and I understand not everything. I go and take a look at the conclusions, but here I was particularly impressed by the content and the whole approach.
So prostate, there is a difference because it heals. There is a strong rationale of use in the use of SRS. We heard that before the alpha beta is low. I didn't say the alpha beta of the organ at risk is roughly 3.5, so the benefit is higher. There is no actually a benefit, and the number of fractions is low. And it's also cost effective because so using the machine for 5 days instead of 5 weeks, it's definitely much more cost effective. So talking about the prostate, there are more clinical studies on the hypofractioning, and fractions are more homogeneous, so usually around 30, 35 gray in 5 fractions. Results are excellent in terms of PSA and progression survival, and also late toxicity is very low. But also on the nodules, we saw these last year at the conference. But also talking about lymph nodes and recurrences to the lymph nodes. So SRS in elderly patients that have comorbidities or a higher echo, we can use SRS instead of chemotherapy. But talking about SRS for the prostate, I thought about this study from 2002. Every time I travel to different conferences abroad, this is a very common, a very simple study that is telling us, and this is based on clinical experience and colorectal cancer. So this study tells us that the recurrence occurs where the primary tumor was. After this study, there has been a wide literature on this and the concomitant boost, and everyone doing radiation therapy, they want to treat this kind of disease because there are several studies with photons, but also with protons. This means that that is a very interesting topic. Photons, of course, are worse, but are more widely used, and maybe it's not any different from other techniques. So, of course, I use brachytherapy, and tell you that brachytherapy is the one working better. But it's just to give you some food for thought. In the literature, there is not that much because they are hypofractionations are very moderate. This is a clinical trial from a group in Milan, and this is a study providing SRS both in terms of prostatic volume but also dominant lesion, and the results will be presented in 2016. I think it's very interesting because the study uses very high doses to the prostate, but also on the nodule. Just to end, in conclusion, we spoke about the LQ model, and I'm happy because I can still use my app on my phone. But I think, as Dr. Morganti said before, this model probably doesn't consider technology, because unfortunately we cannot apply technological data to this model. We were saying before, of course, if I do little things, I cause a very little damage. But the important thing is that I do this and I hit the right site. Of course, we're focusing on the importance of the imaging as we discussed this at the Policlinico Hospital in Rome. And these are the new frontiers, but which are already applied. At my hospital, we are installing the first machine using onboard imaging, which is MRI. I will not talk about this. There are several mechanisms that Dr. Morganti showed us. I don't know if they're working, but research is moving. And this just to say that there is so much. There's imaging, there's new technologies, new techniques that we can give high doses with a tolerable toxicity. Maybe results can improve. And it's short in the long term. In the short term, we can also have better relationships with the other doctors. And of course, patients are happier. Maybe it's also less expensive. And there is space for research. And there will be more. This is just to say that SRS and as we saw today, of course, has a great potential. We have heterogeneous experiences. And of course, what I think the next step is a need for standardization. Thank you.
Grazie Netta.
Thank you, Net. This was certainly a difficult topic, and Professor Morganti always complains, but you're very clever and you managed to give us a speech which was extremely interesting. We have some time for discussion here, general discussion on all the speakers today. You told me, you said that when this topic was suggested, this concomitant boost in SRS has a little to do with our field of care, because there's different times and different doses. But today, technology helps us to say that this contribution can be given. And so having within our standard treatment also some areas for hypofractionations, which can be moderate. And when I was young, when we had problems with the volume, we restricted the volume. Today, in this workshop, this symposium, we've heard how technology can help change this approach. We leave the volume, and the last study of Morganti, we leave the volume as it is, and we give different doses to different volumes in a global volume. So this is the concomitant boost, which is different from which we had in the past. Actually, one of my medical physicists has used a new term, which is cold boost, which is the boost. You identify the area more at risk, and you say, now I want a smaller dose here. So we can also call it a cold boost, and this could be taken into consideration. So you did a very good job. Now I would like to leave the microphone to your questions. Just one brief consideration. You know that I've been studying in the last years. I may have some lacks in my information, and if I start from a radiotherapy with systemic effects and the fact that it has already been demonstrated with the old fractionation, you can find different things in the organisms, cytokines which should be only in that particular area. So today we're starting to see more and more what happens in these therapies. So my question is, at this point, putting together all the speeches today, the alpha-beta ratio, if this is referred to the tumor tissue, it can work, because if somebody receives Caesar died with 123 stabs, but one of them could have killed him the same. So if you give so much to a patient, the alpha-beta no longer helps us, in my opinion, in terms of the efficacy on the tumor, but it's still valid, because in the surrounding tissues, this is where we took the alpha-beta. So it's there precisely in terms of tolerance, because I can imagine that in Hiroshima and Nagasaki there's not been one similar tumor, but the organs with the stereotaxy, allows us to reach the alpha-beta. So the alpha-beta can be useful in the clinical practice because it gives us the information on the tolerance. In terms of what happens in the different targets which we move within the tumor, we need to think about this, because I wouldn't like other people thinking for us in order to understand what to do. In other words, if I, using the various ranges of doses, I start sensibilizing different targets in a cell, I need to understand. In other words, to be more precise, we had been demonstrated that there can be active lymphocytes, but we have not understood the importance of these lymphocytes until we understood that there was an immune checkpoint, that these peripheral lymphocytes were exhausting for the tumoral tissue. This must be a value for us on which to base our work. If these lymphocytes that caused sepsis and others, we manage to disinhibit it, or to understand if there are Treg or other types and act in consequence, we would do what Professor Valentini said. We look locally and act globally. So on this biological approach, we should think and study, and not stop with that particular pathway, because there's bound to be other pathways. And then they'll tell us, put this, but what's happening is that we're doing some translate studies in which we have interleukin and chronotherapy, in which I'm requested to send radiation to a particular part of a tumor, and this works because I can avoid apoptosis, and I can avoid using the dendritic cells. This type of biology is something that we need no overlook, and I apologize for the emphasis.
Per venire incontro a Elvio, che
just to answer, the other day I was at a congress of gynecology oncology, And we were talking about immunotherapy, just to say that we need to learn and get this kind of knowledge. Surgeons, they supposed that removing the lymph nodes probably is not okay, because if irradiate the lymph node, inside we have tumor cells, but also T cells. So if we get the knowledge, if we master the knowledge, we can interact better with competence, not only with the oncologist, but especially with the surgeon.
Da condividere con voi una riflessione.
I wanted to share with you something I've been thinking about. We have this event and we're talking about stereotactic radiosurgery and radiotherapy. Should we still think about stereotactic radiosurgery, because we're not using the frame anymore? We got several techniques like accelerators and CyberKnife, which we will review in the afternoon. But most of all, the difference between radiosurgery and SRS. We all understand what radiosurgery and radiotherapy, both stereotactic, means. Are these just the same fraction, one fraction, or up to 5 fractions? Do we all agree on this? Should RT only be for just the encephalon, or, as Professor Gambacorta said, this is radiosurgery? In other terms, we need to leave this place today with a clear picture of what we're talking. Maybe it's just me with this kind of doubt, because everybody has their own concept. But do we all share these definitions? Thank you. I must, according to a tariff fee based on clarity. We are facing this limitation. The group which was involved, I'm not sure if this was a good or bad thing. For radiosurgery, the single this is already in the presentation. Single shot does not mean number of metastases up to 5, so you can do one single shot on one single shot on the other, and a single shot on the other. This is not the case. The concept of 5 metastases is a concept of all the metastases, which allows the patient to fall in the radicalization category. So I can use either 5 single shots or a fractionated approach up to 5. But 5 is a number which is the result from the imaging, not from the true biological parameters telling me that that's an oligometastatic patient, which is a biologic concept. Today, we have the imaging saying 5, and that is why we stop at 5. The 5 as a number.
Correct this idea if you think that it is wrong, and I hope that the translation is very good. Il numero fino a 5.
The number up to 5 is the fact that when you have up to a certain latency of time, these tumors represent a clone which can be biologically better, which must be firm in that seat and not have given anything else. I hope I answered the question. Therefore, the radiosurgery is a technique which you do on one session, on one patient. On another patient, up to 5 times, you will be allowed, because they have different types of metastases. This will allow it to do 1 or more sessions.
It's a different question. When we give 5 sections to the brain, 1 or 2, are we talking of radiosurgery or radiotherapy? Because this is very important that we define this, clarify this, and to remove that tumor in little pieces, or do 5 little operations, separate operations. What I'm saying at an international level. So speaker speaking off the microphone. Okay. The radiosurgery is just one. So multiple conversations speaking off the microphone. Off the microphone.
Di frazioni che utilizziamo.
Ci vorrebbe Valentino qua. Alessio, vai.
Ragioniamo su focolaio tumorale. Lesioni cerebrali.
We're talking about brain lesions, single fractions. Just foci. Stereotactic radiotherapy and fractionated.
C'è chi dice fino a 5.
And some people are saying up to 5. In all publications currently available, when we talk about radiosurgery, there is a trend of doing irradiation on the metastasis in just one fraction. All comparison studies between radiosurgery, radiation therapy, they compare between patient treated in a single dose and multiple fractions. And recently, there's been a comparison study between the two techniques, because for brain metastasis, fractionated was better than single dose. They were doing this kind of classification, and this is valid for intracranial and extracranial, and I think this is quite clear.
Sono d'accordo.
I agree on what you say on this type of classification. Just a general thought, and we all agree on this. What I think is some day-to-day experience, and on the fact that probably we have reached a time in which we need to talk to the others as well. They call us for they got a patient, can I come? And then I come, I get there, and then they tell me, well, I thought he had one metastasis, but he has 2, so you're no longer needed here. And so I asked, well, we sent him to chemo, and I agree on the chemo, but 1 or 2. We could have treated this patient before. So call Morgante and then stop him, because the patient now has 2 metastases. So maybe I told him if I got here sooner, the second metastasis wouldn't have turned out. But apart from this, a single metastasis at the liver, breast, and I send him to the oncologist, and then we can agree on decide on what we can do. So I send this patient to the oncologist, which does a thermal ablation, and I say, well, I didn't send the patient to do a thermal ablation. And I hear a lot in Bologna, at Rizzoli Hospital, metastasis with a single bone metastasis. Now we have something new. We have electrochemotherapy. You put a series of needles inside the bone, and then you do the electroporation. And in the meantime, you give biomycin. Well, they're very satisfied with the results. So we have a tool which works. Now we need to understand how the others can use this as well.
Erano 2 diversi oncologi medici. all'inizio.
So, the experiences we have and links with oncologists, they're all different. So I can irradiate 3-4 lung nodules. I'm not going to give the results because we know the results, we know how it works on lung nodules, but first they see the surgeon and then they find 2 nodules, one on the left, one on the right. They're perfect. And then the patient is referred to the medical oncologist and they say, this is systemic, you treat it. But unfortunately, we're not present in other very important conferences and congresses. And we cannot let them understand that an increase in the survival and control of these patients, the majority of this is due to an improvement of the radiation therapies and techniques. This is a message that we need to convey. Our patients are very happy to go home quickly with a part of the problem resolved.
In order to stress how this is a cultural issue of the radiotherapy, which is not much known by our fellow oncologists, a couple of weeks ago, an article on La Repubblica newspaper, an English study saying that whole brain harms the patient. And the whole brains have very bad patients in terms of cognitive approach. And so I read the articles and this article, and the problem here is the selection of patients. The English, and I hope there's no English people in the room today, the study of how many patients in the pathology departments have been reviewed who have done chemotherapy done 3 days before they died. So it's important, and this must be a very strong message given by the scientific world. There must be strong and clear messages that radiotherapy helps and costs very less, much more less than other medications, which in their experimental phases should be extremely more selected on specific pathologies. Immunotherapy is widespread more and more, and having people on stretchers or on wheelchairs who are doing a protocol in a hospital that is not authorized to do them.
Ale, this is a very important point for this kind of therapies. We're talking about 200,000 euros per year per patient. So it's almost a hospital budget. It's the same. It's always the same. We buy a machine every 10 years and they buy a medication, a drug every day. So there is also the interest of pharmaceutical companies.
Just a very quick comment on this, on everything that's been said up until now. My opinion is that what we need to avoid, also based on our previous experience in radiotherapy, is that, Alessia was saying before, try to spread knowledge, but at the same time being secure and being decisive on what has already been established and what is still on investigation level. And this can only be done by promoting studies that are operational, multicentric, and on the consolidating aspects and also on the experimental phase can give us the same approaches and same behaviors in terms of volumes and how to assess the radiobiology aspects and the interventional radiology aspects. So we must make an effort to consolidate this information, to merge this information, and uniform them as much as possible. Let's try to avoid a non-homogeneous approach, because these can foster messages which do not deliver safety and certainty. And this is why we're still having issues on a therapy which is obsolete in some cases. So we must make an effort to capitalize this technique on what we already have established and on the investigational approach, but with a homogeneous language.
Yes, everything sounds beautiful, but I want to say that we should avoid discussing oncological cases outside of oncology departments. We should start from this, because if we don't speak out loud about the treatment of these patients, so this should start from the basis, from the grounds, and then spread this kind of culture. We should refuse treating patients that have not been discussed by a multidisciplinary team. We should start from this. I fully agree.
È arrivata l'ora del pranzo. Grazie.
tutte le prove con questi hanno dato per scontato che si andava in amplificazione. No, se gli dai lo switch di quel PC così si vede, fa delle prove sullo schermo. Sì, si è già attaccato, mi pare che volesse fare una prova. E tu hai un ricevitore lì? Ah. Adesso ti arriva? Arriva basso. Qua è abbastanza alto, anche troppo. Sì. 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 Ehi, prova, sì, ehi, sì, ehi, prova, sì. 1, 2. 1, 2, 3, prova, sì, sì, prova, ehi, sì, sì. Prova, sì, ehi. Prova, sì. Piano che sta innescando, re? Prova, sì, ehi, prova, sì, ehi. Sì, infatti ribatteva, c'era un ritorno in più. Sì. Ok. Se volete, non so. Sì, ehi, prova, sì, ehi, prova, sì, sì. Ma ti serve una mano? Ehi, prova, sì, sì. Salva, ti serve una mano su? Prova, sì. Prova, sì, sì, sì. Sì, ehi, prova, sì, ehi. Prova, sì, prova. Ehi. Sì, prova. Prova, sì. 1, 2, 3. Prova, sì, sì. Prova, sì. Ehi, sì. Prova, 1, 2, 3. Prova. Prova, sì. Va, 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 va. Prova, prova. Ti serve una mano? Prova, sì. Ok. Sì. Ehi, ehi, prova. Prova, sì. 1, 2, 3, prova, sì. Basta? Senti, vado a controllare comunque pure in cabina. Sì. Vale, mi fai un favore?
Dimmi.
Ci parli ogni tanto?
Ciao. Buonasera. Devo parlare.
Pregherei la sala di prepararsi alla riapertura dei lavori.
Ready to start? Dr. Tombolini will be the moderator for the next session.
Sì, qua.
Okay, we start. The first speaker, Professor Verellen, State of Art in Europe. Thank you very much.
Thank you, Mr. Chairman, and thank you for the invitation. I seem to have a small problem with the computer here. Switch it off.
Allora ne approfitto per ringraziare gli organizzatori, per Carlo Gentile.
So I take advantage to say thank you again to Carlo Gentile, Dr. Chianciani for this wonderful event. I'm sorry the room is too small, but at least we know how many people will participate in the following years.
Oops. Okay. Okay, we're set. Okay, thank you, Mr. Chairman, and thank you for the invitation of being here. It's quite a challenge representing the state-of-the-art of stereotactic radiotherapy, stereotactic body radiotherapy in Europe, but I'll try my best. So this is a short overview of the coming half hour, basically, of what I'd like to present or share with you. Usually when I give presentations, I want to open a discussion and give some food for thought. So I will discuss a little bit the words of stereo in the stereotactic definition with a short history, but some of it has already been alluded to by Morten Hoyer this morning. And then I'll talk a little bit about technology, the mainstream versus dedicated machines, and whether or not we should go for standardization or individualization of the patient. And then I would love to end with a few open remarks and challenging points that I'd like to discuss with you, or at least give some food for thought to take home with you, because I won't be giving the answers. Before I start, I'd like to make a disclaimer. That is that I will be talking about some technology here, and for some technologies I might sound a little bit more optimistic than for others. That doesn't mean that one technology is better than the other, it's how you use it. And I use this metaphor of a table tennis player. It reminds me of when I was 16 years old. When I was 16 years old, I bought this very fancy table tennis palette. And I was very happy with it because I had a very fancy, expensive table tennis palette, and now I could play table tennis. But I have an uncle, and he used to be the provincial champion of table tennis when he was young. And so he challenged me for a little game. And he was using a very cheap wooden palette without anything on it. And maybe it's a bit sad to tell you, but you probably see this coming. I lost that game with 15-0, 15-0, 15-0, because he was playing much better than I was. So basically what I'm saying here is that a fool with a tool is still a fool, okay? So it's not the equipment, it's how you use it. And so I will be mentioning a little bit about equipment, but please bear in mind that I don't have a real preference for any equipment here. So. Okay, so stereotactic radiosurgery, stereotactic radiotherapy, it's not new. It's related to everything that is radiotherapy. But I like to remind you of this metaphor. I'm from Belgium, so I'm using Belgian painters. or one famous Belgian painter in this case, which is René Magritte. René Magritte made this painting of a pipe. And on this painting of a pipe, he said, "Ceci n'est pas une pipe." This is not a pipe. And this is a bit confusing, but actually it's true. I mean, this is a picture of a pipe, not the pipe itself. And in radiotherapy, we are treating pictures of tumors. We are not treating the tumor, we don't see the tumor. And that's our problem. And this is where the stereotactic radiosurgery came into being, basically. So hence my little short history on stereotactic radiosurgery, stereotactic radiotherapy. So the stereotactic frame, where's my pointer here? The stereotactic frame was essentially introduced because it was assumed to be or to ensure a sub-millimeter accuracy for surgery or radiotherapy. So you had a rigid, fixed coordinate system that was more or less invasively fixed to the skull of the patient. And then you had this was a reference frame. And so using this reference frame, you could use coordinates based on imaging to actually localize the tumor when you were treating the patient, basically. And so this is then a very short history, but it's always nice to look at history, of the intracranial frame, if you'd like. 1908, Henry Clark and Victor Horsley investigated on the use of this kind of a stereotactic frame on dogs, actually, at that moment. And then in the 50s, as Morten Hoyer presented in his presentation, you had the big breakthrough of Lars Lexell with the gamma knife, actually using this stereotactic-like frame for then brain treatments with photons and protons, originally protons, actually, as Morten mentioned. And then in the 80s, this entire concept of the gamma knife was then translated to LINAC-based radiosurgery, but still using this frame. And so this was the pioneering work of Osvaldo Betti and Federico Colombo. Obviously, for the brain, this was easy. And so the stereotactic radiosurgery, the name speaks for itself. You're using a stereotactic frame to localize the tumor inside the skull of the patient. But this idea was then investigated to extrapolate to the body, basically, extracranial. And again, and I think it's nice to mention again the group of Karolinska, because Lars Lexell was a neurosurgeon working at the Karolinska Hospital in Stockholm. So he was a pioneer in the stereotactic radiosurgery for the brain. But it's actually the same group, and this time with Lars Lexell and Blomgren, who sort of translated the idea of the stereotactic frame to a stereotactic body frame. And so it was originally introduced as an immobilization, but also as a target localization system. But then, of course, image guidance comes into the picture. And so this is a study from Wolf et al. It's already an old study, but also Lax, the one who basically invented the stereotactic body frame, they both confirm on the fact that if you would apply the stereotactic body frame as an only device to position the patient and localize tumors, you might end up with big margins and big misses. And actually, Lax also said this in one of his famous publications, that you always need a CT prior to the actual treatment to be absolutely sure that you know what you're doing so that the patient is positioned correctly in this body frame. And so basically, you still require some kind of image guidance. And this is then the recommendation of the AAPM Task Group 101 that states clearly that body frames and fiducial systems, they are okay for immobilizing the patient and some sort of coarse localization of the tumor, but they shall not, and the word shall and not is very important in English, they shall not be used as a sole localization technique. And this is then the introduction of, or the start, if you'd like, of image guidance. And so there was this evolution of image guidance in the 90s, early 2000, with the introduction of cone beam CT. It started all with electronic portal imaging in the early 90s, and then it was extended to having these cone beam CT systems that are sort of integrated into the LINACs. And then you've got these dedicated machines, such as the Viro extended or a limited edition, if you'd like, because the Viro is no longer commercially being explored, and then the CyberKnife, of course. And so the idea of image-guided radiotherapy is basically that we want to replace the stereotactic device with external coordinates, and we want to use direct imaging with online correction, basically using the internal anatomy of the patient rather than an external reference system. And so that's the general idea. And this brings me to one of the questions that I would like to throw in this audience so that you think about although I have my own answer, of course. So I'm using this title, potato, potato, tomato, tomato. You'll see the title coming back a few times in my presentation. So the name stereo, we're referring to this as stereotactic radiosurgery, stereotactic body radiotherapy. But basically, if you're using image guidance, you can ask yourself the question whether or not the word stereo in stereotactic is still a valid name. On the other hand, of course, we're all using it. It's the same with IMRT. We're all using IMRT, but if you think about it, a simple block or a multi-leaf collimator to create or shield an organ at risk is also some kind of intensity modulation. It's a binary intensity modulation, dose or no dose, but it's also intensity modulation. But we're still using the term intensity modulated radiotherapy for something where we are using different levels of intensity inside the same treatment field. And so in that respect, we are still using that word, and it sort of sticks. And I think the same holds for stereotactic body radiotherapy, stereotactic radiosurgery. We've been using the terminology stereo for so many years, so why change it? But please realize that we're not referring to these frames anymore. Most of the techniques that are, or centers that are now applying stereotactic radiosurgery, stereotactic body radiotherapy, they are not using these frames anymore. Good. Brings me to SBRT, so the stereotactic body radiotherapy and motion management. Very quickly, if you want to do motion management, these are the variables that you have to cope with. There is motion inside the patient in the time frame of seconds. So this is breathing, peristaltic motion, heartbeat of the patient. There is motion in the time frame of minutes, patient motion, tumor drifts, motion management that needs to take care of variations inside or variations of anatomy that is in the time frame of days. Setting up the patient from day to day if it's a fractionated treatment. And then there's, of course, the changes in anatomy that takes place in the course of weeks, basically. Shrinkage of the tumor, progression of the tumor, weight loss of the patient, these kind of things. And so motion management tries to cope with all these issues. But when we talk about stereotactic body radiotherapy, basically we're referring to this here, the time frame of seconds and minutes. And so why do we need motion management? Well, again, I won't be going too much into the details, but very briefly, basically there are two reasons why we want to do this. One is that because of the motion of the tumor is moving along, you get some kind of a blurring of the dose, and you want to somehow cope with that blurring. You can do this in different ways, but you need to know that there will be some blurring of those. The other problem is that when you start doing IMRT, dynamic multi-leaf collimators, so you try to modulate the intensity while you're treating the patient, then you might have, or you might end up with some kind of an interplay with the motion of the tumor and the motion of the leaves. And not only the motion of the tumor, but also the motion of the organs at risk. And they're not moving in the same direction, so you have an interplay that might be quite challenging. So we need to manage this motion. And this is the big challenge of SBRT, if you'd like. And again, I'd like to make things very simple, and so I try to categorize them into two ways. And I like to call one solution a passive solution and the other one an active solution. With passive, it means that you realize there is some motion, you try to quantify that motion, and you adapt your treatment strategy according to what you know in advance. So this is a motion management that is prior to the delivery itself. Active motion management for me is that you monitor the motion in real time and you adapt while you are treating the patient. So this is typically breathing synchronized irradiation, if you'd like. So how does this work in practice? So this is a typical example of a passive approach. Again, I'm not saying that one approach is better than the other. You just need to know what are the advantages and disadvantages of each technique. So a typical way of doing this is to define what we call the internal target volume. So you try to monitor, you try to classify the motion or quantify the motion of a tumor while a patient is breathing, typically using a 4D CT or inhale or exhale CT. And using this information, you try to define a sort of an internal target where you think the tumor might be during the breathing cycle of a patient. And then you add a margin to that, and then you got a PTV, and this is the PTV that you're going to treat. Please remind that if you're using the concept of planning target volume, and you're using this margin formula that almost everyone in all over the world is using the margin formula of Marcel van Herk from the NKI in Amsterdam, the concept of ITV doesn't apply there, because in this formula, the ITV is one of these errors here. And so you should add them quadratically. And so if you single out the ITV from this formula, you overestimate the effect of the ITV. So you're bound to be treating too much healthy tissue. Now, most of the people that start with SBRT are using an ITV. And again, this is not a bad idea, because it is a safe approach. You might be treating too much healthy tissue, but it works. As long as the toxicity is not too high, as long as the volume is not too big, and in most cases it is limited, you can get away safely with this ITV. So I'm not saying ITV is bad, but please realize that the volume might be a little bit too big. And so this is then how it might work in clinic. So this is just a picture from my former department. Just to give you an example, so this is a cone beam CT that was acquired prior to treatment for this non-small cell lung cancer. And in green, you see the PTV margin, and you can clearly see that the tumor, the GTV, is not nicely centralized inside this PTV. So we shift the images to centralize the tumor in this PTV. We can actually superimpose the dose distribution to be sure that the tumor is covered, or the GTV is covered with the appropriate dose, and then we can treat the patient. That's typically how you use an ITV. As I said, with an ITV, typically you're treating too much healthy tissue. So this is what's happening. You're treating this entire volume where the tumor might be during the breathing cycle of a patient, so you're irradiating a lot of healthy tissue here. Another approach, and this is a cartoon I borrowed from Matthias Guckenberger from the Zurich University. Another approach is that you narrow down this field a little bit, and this is typically called the mid-ventilation, mid-positioning technique. You narrow down the volume that you're going to irradiate, but you escalate the dose in this smaller volume. So it's a smaller volume, so you can give a higher dose, and giving a higher dose compensates for the fact that sometimes the tumor is outside this volume. And so that's the idea of the mid-ventilation, mid-positioning technique. So most of the time, so basically the tumor is only 10% of the time at the 50% of the isodose. And so this is only 5% of underdosage, basically. And so you can compensate this easily by dose escalating to a smaller volume. So that's the idea. Okay, so next. So these were the typically passive solutions for SBRT. You can do active breathing synchronized irradiation. And again, there are typically two solutions. One of them is tracking, the other one is gating. So with tracking, you actively want the beam to follow the tumor while you are irradiating the patient. With gating, you wait until the tumor is in the right position and then shoot. Both of them are equally usable in clinic, basically. The problem with tracking is that you have to basically find a way to move this entire LINAC head to follow a moving tumor with sub-millimeter or with millimeter precision. And you need to realize that this LINAC head is typically something like 1 ton. So you want to have 1 ton of machinery following a very small, delicate tumor inside the body of the patient with millimeter accuracy. This is not easy. And so again, some solutions have been thought of. I'm just using a few examples here and a few movies. One of them is the breathing couch, or the moving couch. So it's basically having the couch to compensate for breathing motion. Now you can imagine if you're lying on a couch and the couch is compensating for the breathing motion of the tumor, then you might get seasick. So this has been investigated in a few centers, but this one is becoming more popular now. It's using the multi-leaf collimator. So you're using the multi-leaves to follow the tumor, and it's called MLC tracking. It was used in last year. They started treating prostate patients because those are the easy ones. But I've just read an article of the group of Paul Keel in Sydney, and they just started treating lung patients with this technique. So it's now clinically being used on patients. And actually, there is a group that is combining these two. Why are they combining these two? Because this is very nice if the tumor is moving in the direction of the leaves. But if the tumor is moving in the other direction, then these leaves here have to move very fast to compensate for motion, and that's not so easy. And also because typically you're going to use a rapid arc today. And with a rapid arc, you're already moving the leaves very quickly, so you're already limiting the multi-leaf collimator to the limits to the mechanical limits. And then you're going to add motion also to that. So that might be, you have to make a compromise. Either you're going to follow the tumor or you're going to modulate the intensity. That's a bit of a tricky question. And then, of course, there are these dedicated machines. I'm losing my pointer all the time. You have these dedicated machines here like the Vero and the CyberKnife. And the Vero and the CyberKnife are basically machines that are designed for tracking. So these are two examples. This is me lying on the couch. I hope that the beam was off when they were doing that. But basically the idea is the same, that you have the beam line is following the tumor, and then you get something that looks like this in the patient. So we call this a sticky dose. So the dose is actually following the tumor. This comes with a price. I mean, this is not, it looks nice, it looks easy, but it isn't. Because in order to do that, you need to first monitor the respiration of the patient. And once you've got the respiration signal of the patient, you need to correlate this respiration signal of the patient with the internal motion of the tumor, which is not necessarily the same. Because if you have a patient that is in the beginning anxious, there will be some thoracic breathing. And after a while, the patient relaxes, it will be abdominal breathing, and it means that the breathing pattern changes, but maybe the tumor pattern motion is not changing, or the other way around. So you need to correlate these two constantly during treatment. And then you need a prediction model. And this prediction model is because you're going to tell this 1,000 kilogram machine to go to a certain position. But by the time this machine is at that position, the tumor is already gone. So you need to predict where the tumor will be within the latency of your machinery. And so you need to predict where the tumor is. You've got a correlation model, you've got a prediction model. And then you need to realize that you're interfacing a machine with a human being, and this correlation model and the prediction model, they expect that things are predictable. But the patient is by default unpredictable. So he will be coughing, he will be moving, and so you have to cope with that. And this brings me to my second sort of philosophical question that I'd like to throw in the audience. The first one was the name stereo. Do we still need it? The other one, again, tomato, tomato in this case. Do we need mainstream state-of-the-art equipment, classical Linacs, that are adapted, upgraded to do something like motion management, or do we need dedicated machines? So this is the Cobalt machine that was upgraded to a Linac with all the IGRT equipment, or do we need these dedicated machines that are designed for SBRT? The basic question that you want to ask here is, can I use an ITV mid-ventilation approach for most of my patients, or do I really need tracking to reduce the margins and avoid toxicity as much as possible? And in order to do that, you have to look at this slide. If you are using a stereotactic body frame, you still need a safety margin of about 1 centimeter to be sure that you hit the tumor. If you're using EPITS, you can reduce this margin with about a few millimeters. If you use cone beam CT every day, you can get away with a margin of about 4 millimeter. And if you're using tracking, you can reduce margins to 2 millimeter. Never reduce margins to 0 millimeter, because that's basically a big mistake. Because there's always an uncertainty that you need to take into account. But if you look at the amplitude of the tumor and the safety margin that is needed to cope with this amplitude, then you see that if the amplitude of the tumor is less than 1 centimeter, you don't need margins bigger than 2 millimeter. If the amplitude is higher than 15 to 20 millimeters, you start to have bigger safety margins that are required to be sure that you hit the tumor. So it's only for those tumors that have a motion amplitude that exceeds 10 to 15 millimeters that tracking and gating might be a benefit. And this is a very small proportion of your patients. If you look at 4D CTs of your patients, it's only a small group of patients that really require these small margins. And so if this is another way of looking at it, so this was a slide that was calculated by Misha Hogeman in Rotterdam on the CyberKnife, basically calculating based on the amplitude of motion what kind of a safety margin that you need to be sure that you always will hit the tumor. And of course this differs for lung and for liver tissue because the penumbra is differently. But if we focus on the lung patients, then if the amplitude is below the 10 millimeter, you don't need margins that are big, basically. That's what I'm trying to say here. And there's another slide that I like to use when I give presentations, and it's a slide that I borrowed from Michael Brada. And I think he makes a very strong point here. When it comes down to motion management and SBRT, have to watch the time, I think. You have to realize that you have to make a choice. Either you're going to be intensive with respect to technology, or you're going to be intensive with respect to patient compliance, basically. So you can ask the patient to have normal breathing, and then you need some kind of technology to compensate for this normal breathing. But you can ask the patient to coach the patient to go to regular breathing, to a voluntary breath hold, to an imposed breath hold. You can actually go to sedation and anesthesia of the patient so that the patient stops breathing. And if the patient stops breathing, you can treat with any technology, basically. But when you start having the patient to be more and more uncertain in the breathing pattern, you might have to compensate more and more with technology. But it depends on your own department and your own technology where you are along this slider. It's a choice you have to make for yourself. Good. So, a few slides with some challenging remarks. Again, please remember, and I hope that with my presentation it's clear that the perfect tool doesn't exist. It's just how you use it. So think about the presentation or the slide of Michael Brada. But it works. And this is the good message. So again, I won't be reading all these, but this is a study of a publication of Jan van Meerbeek, actually stating that in view of low morbidity and mortality, radiotherapy should be considered the preferred local regional treatment for these patients. And if you look at the pioneering work of the Karolinska Institute, and also this is just a small group of publications that have been out there in the literature on SBRT, and if you look at the outcome of these patients using SBRT, we actually have very nice results. And so if you look at what we can do today with radiotherapy, and specifically with the high technology, high precision radiotherapy, we can now have this margin reduction, simultaneous integrated boost, the reviewed dose fractionations like hypofractionation, the biological conformal radiation therapy, adaptive radiotherapy, and actually we can start doing re-irradiation of our patients in a safe way. So this is all possibilities created with basically the technology behind SBRT. So what I'm saying here is image-guided radiotherapy and IMRT. Good. Remaining challenges. What we really want to do, is we want to assess what was the true delivered dose, not the planned dose, the truly delivered dose of the patient, to evaluate the dose-volume relationships, to predict toxicity and tumor control, both in a primary setting and in re-irradiation setting. And this brings me to my last slides with a few challenges that I would like to present to you. Some of the challenges are related to dosimetry, and I will give some examples. The dose calculation and dose reporting, deformable image registration, image guidance and adaptive radiotherapy, knowledge engineering. And then, of course, there is the healthcare and the economics, which is becoming more and more a complex issue. And I think it's not only in Europe, I think it's also in the States becoming an issue that we have to take into the equation. So, dose calculation. I won't go into the details. I hope that you know the differences between type A and type B planning systems. So type B planning system is typically Monte Carlo, where the dose calculation in the heterogeneities inside the patient's body are much more accurately modeled. So the dose calculation is much more accurate or resembles much more the reality inside the patient compared to the old dose calculation algorithms. But all the data that we have, the clinical data, is based on the type A dose calculation algorithms, and today we're using something different. And this brings me to dose reporting. And this is just one example. At a certain moment, we switched from a type A to a type B planning system, and we were discussing with people that were using the same technology. So the Viro system that was used in Brussels and the Viro system used by the Kyoto University in Japan. And when we were talking about switching to a type B planning system, we saw that the number of monitor units for the same patient, the same prescription, using a type B planning system was much higher than what we were used to be prescribing in the past using the old calculation algorithm. The Japanese people didn't see that. They said, no, we didn't change our monitor units. We have exactly the same monitor units as in the past, switching to Monte Carlo. And this was because they were prescribing the dose to the ISO center. We were prescribing the dose to the edge of the PTV, which is a big difference. So we thought we were doing the same thing, but we were not. And this brings me to this slide. Giving 3 × 20 gray in Brussels is not the same as giving 3 × 20 gray at the Free University in Amsterdam. Although we think we're doing the same thing, but they're using an Elekta cone beam CT with VMAT, and we're using tracking completely different situation, completely different way of prescribing dose, and the doses to those patients are completely different, although we both think we're giving 3 times 20 gray. Even if you're using the same equipment, what I just showed you, using the Vero in Brussels and using the Vero in Kyoto, same machine, different prescription of dose, so the 3 times 20 gray in Brussels is not the same as 3 times 20 gray in Kyoto, although we are using exactly the same machine. So something to think about. And this brings me to the way we prescribe dose. This is the target, and in classical radiotherapy we say that we want typically 95% of the dose to cover 95% of the target. But in SBRT radiosurgery, we're going to 80% of Dmax or 60% of Dmax, and you get these kind of doses, a very high dose in the center with the same dose at the edges of the tumor. And so this is not the same as this, although when you report it, you say exactly the same. You say we are giving 3 times 20 gray, but some people are giving 3 times 20 gray, where is my pointer, like this, and some are giving 3 times 20 gray like this, and so they're giving a much higher dose to the center of the tumor. So it's not the same thing. And so this is another nice example. This is a slide that I borrowed from Ian Padek. So he was looking at stereotactic radiosurgery in the brain with a gamma knife. So basically, he said that suppose you have 2 lesions. One lesion is 8 millimeter diameter, the other one is 11 millimeter diameter, and you're both treating them with a different collimator, so the same collimator, sorry, 8 millimeter collimator, and you want to give 25 gray. And if you give the 25 gray to the 80% or 25 gray to the 50%, you get completely different maximum doses. And so this is another way of looking at it. So this is a tumor where you have 90% coverage, 95% coverage, 100% coverage, and a 0 margin. And if you look at the center dose, the Dmax goes from 30 gray up to 45 gray. So this is a 48% difference in dose, although we think we're doing the same thing. So, brings me to dose prescription and margins. Maybe the PTV D95, which we typically use, might not be a good predictor of the minimum dose to the GTV. So maybe we should stop reporting the dose that is delivered to the PTV, because it makes no sense. Maybe we should start reporting the dose to the GTV, the mean GTV dose, because that's a very robust calculation. And so if we say we prescribe the dose to the PTV margin, but we report the dose as the mean dose to the GTV, and this is something that everybody can calculate. And so you can compare your treatment with another treatment. And basically, and this is also some food for thought. If you're prescribing the dose to the PTV margin, please realize that the PTV margin is in lung tissue. And in lung tissue, there is the highest uncertainty in your dose calculation. And this is where you're going to prescribe your dose. That makes no sense, because there is a big uncertainty in the real dose that you're giving in the lung tissue. And this is where you're going to prescribe the dose. So even within patients or within the same center, you will have big uncertainties. So please be careful there. And then you have all these very nice tools where you have deformable registration that allows you to accumulate the dose during a breathing cycle, or for different fractions, for instance. And this brings me to another challenge, because all these calculations, it looks nice when you look at it, but they all are based on deformable registration. And deformable registration needs to be quantified. It might look nice, but in reality, you don't know what you're doing. You need to be absolutely sure that the right voxel is going to the right voxel when you use a deformable registration tool. And this is just a study that we did in our department several years ago, where we were comparing 2 commercial, and I censored them because the companies were not so happy with the results, especially this company. But we compared 2 companies using, and if you have a deformable registration algorithm, please note this website here. This is a website from the Lyon University, where they have different CT scans, 4D CT scans of patients, and they identified in all these phases, in all these CT scans, anatomical landmarks that could easily be located in all these phases, and they can be used to quantify how good the deformable registration works. You can just download these data free. So if you have a deformable registration tool, download this information and you can test it. It's for free. And then this is just an example. We used this phase as a reference phase, and then we used the other phases to look how good the deformable registration would fuse this image back into that image. And the results were really bad, because in many cases we had errors up to 1 centimeter. And you're using this for dose calculation. So again, doesn't make much sense. And then, as I mentioned before, we're using the, I have to watch the time, I think. We're using data from the past, and the data from the past was calculated with type A planning systems. And one of the things that we're also starting to do more and more with SBRT is re-irradiation. And there is this nice Quantec report. It's been used already a few times during this conference, but there is almost no data on re-irradiation. That's one problem. The second problem is that there is all the data that you see here is those or data that was generated with planning systems of type A in many cases. So it doesn't refer exactly to what you're doing today in your clinic. And so what I'm trying to say here is with those calculation and radiobiological models, and we've been discussing these models this morning, is that you have to be very careful with the dose that you see in your planning system, because what you see is not always what you get. And with these models here, you have to realize that if you put garbage in, you will get garbage out. And so the linear quadratic model, for instance, that we're using today, it might be useful. And this is a quote from Professor Fowler. All these models could be useful, but they are wrong. Okay, but they might be useful. Good. Brings me to the last point I'd like to make, if I have a few more minutes. Okay, good, thanks. I'm very active in the ESTRO, and in ESTRO we have this new vision, the 2020 vision, saying that every cancer patient in Europe will have access to state-of-the-art radiotherapy. And this brings me to another point that I'd like to mention with you when we talk about technology and SBRT in Europe, or maybe even in the world. And that's healthcare and the cost that comes with it. And I like to make this statement here. The true cost of something is what you give up to acquire it. If you have a lot of money, everything is very cheap. Okay? But if you don't have much money, everything is very expensive. And so if a new expensive technology is introduced in the clinic and it comes at the expense of the fact that the average cancer patient will not be treated in the appropriate way because all the money goes to this highly high-tech new device, then this high-tech new device is a very expensive machine because it prohibits the majority of the patients to be treated in a high-quality way. And I think this is a very strong statement that I would like to make. And the obscene situation that we see is that the internet is feeding this, and the patients like that. Because if a patient is given the option of a 30,000 treatment versus a 3,000 treatment, regardless of the fact that we have evidence to show that both treatments have the same outcome for the patient will choose this one, because more expensive will mean better, right? And this is, I think, a very obscene situation that we're facing today. So, again, the internet feeds this notion. And this brings me then to my last slide. Again, potato. Do we need standardization versus individualization? Do we need dedicated machines, or can we do radiotherapy, high-tech radiotherapy, high-precision radiotherapy, like stereotactic body radiotherapy? Can we do this with mainstream machines? And I think the big challenge today is that we need to increase the efficiency. And increasing efficiency, if we do that, we have more time for optimization and individualization. And I think this is a very strong statement in favor of standardization, because if you standardize, automate treatments, you have more time to fine-tune them. Now we're spending too much time in generating plans, but if the plans are automatically generated and we tune them afterwards, we can save time. Standardization also works in favor of safety and quality. So if you increase the standardization, you have safety and quality that are more standardized. The same is that it creates new possibilities for dose tracking and adaptive radiotherapy, and it creates possibilities for knowledge engineering in radiomics. And that's, I think, a very important statement. So I think I've thrown a lot of ideas in your face. So I'd like to end up with a few concluding remarks here. The good news is that stereotactic radiosurgery, stereotactic body radiotherapy is now part of the mainstream radiotherapy. I'm one of the course directors of the SBRT course at ESTRO, and when we started there were only a few centers that were doing SBRT, but in 3 years' time, basically all the participants at the course are actually doing SBRT today. And this is, I think, a very nice development. Although there are still some open issues, and I hope that I mentioned a few of them and that some of them will stick and that you take them home with you to think about. So please think about whether or not we need mainstream technology versus dedicated equipment. maybe we don't need these high fancy dedicated equipment. We can get away with mainstream technology. Think about it. Think about this in view of the world economy and the cuts in healthcare, because we are really challenged with this problem. And then think about whether or not standardization is a good idea. I just gave you some pointers. I have my own ideas, but I don't want to force my ideas in the audience. I'd just like you to think about it. So thank you very much.
Thank you very much. Thank you very much.
Grazie.
After the second lecture, and now I would like to introduce Professor Hack, State of Art in USA, State of Art of Technology.
Well, thank you, Mr. Chairman. So I'd like to take this opportunity to thank the organizers for inviting me in this 4th annual, the International Symposium that you are holding. I had an opportunity to talk with a few participants here. I understand that there are participants from many countries in Europe. And this has truly become an international symposium. So congratulations to Pier Carlo and the organizing body here. So my topic that was assigned to me was to talk about state-of-the-art technologies for SRS and SBRT in the USA. It's a huge undertaking, 30 minutes to talk about all the technologies. It's a large undertaking. So what I have decided is that what I'll do is provide a brief overview of some of the technologies. And I'll take a completely different path of presentation. Rather than showing PowerPoint slides, I'll show you a lot of movies. So get ready to see movies. It'll be a movie theater. And in doing so, what I had to do is reach out to different vendors to get the movies. And what that does is vendors, whenever they show movies, there are a lot of marketing material. So please disregard those. I have no personal interest in any of the technologies or any of the machines that are out there. And the rationale for showing the movies is that there may be many of you in the audience here who may not have seen the inner workings, how some of these technologies work. So the thought was that instead of hearing me talk from PowerPoint presentations, if you see movies, then it may stick to you, may benefit more from that. So I have no conflicts of interest. Here is an outline of my presentation. I'll talk about the Gamma Knife Perfection and Icon unit, talk about Varian Edge and TrueBeam STX machines, the CyberKnife M6 with Incise MLC, and I'll talk about a new machine, it's Reflection. This will soon be marketed in the US and possibly in Europe also. So this has some nice features when it comes to SRS and SBRT. And then I'll summarize. So radiosurgery really started with the treatment of intracranial tumors using Gamma Knife in 1951. Since then, the Gamma Knife, the models of Gamma Knife has evolved. There has been the U, B, C, 4C, Perfection, and now the Icon unit. They're all these units. In Pittsburgh, we actually had all of these models. We got the first generation of the U unit and the 4C unit. Pittsburgh is considered the Mecca, if you will, for gamma knife radiosurgery as well as LINAC-based radiosurgery. So this is what a perfection system looks like. The perfection has 192 cobalt-60 sources, and it has 3 collimators. It has a 4 millimeter collimator, 8 millimeter collimator, and a 16 millimeter collimator. So shortly you'll see that let's see what I can find. So this is the patient positioning system. This can move, sorry about that. So this patient positioning system can move, I have to get used to this here, okay. The patient positioning system can move laterally, longitudinally, and vertically. And what it does is, it transports the patients, as you can see, inside the unit, and moves the patient appropriately so that the center of the target is at the center where all these 192 beams intersect. And what you see here, so let me show that I can find where I was. So what you see here, sorry, it's rewinding. Let me fast forward. So this is where the perfection has what is called 8 sectors. And each of these, what you see on the screen, that's where the 192 cobalt-60 sources are positioned. And each sector has 24 4 millimeter collimator, 24 8 millimeter collimator, and 24 16 millimeter collimator. So during treatment, the sources can move and place them on the different collimators. So what you have here, if you can see, that these are the sources, and they're positioned at the 4 millimeter, 8 millimeter, and 16 millimeter collimators. And so you can actually do dosimetry by placing these sources on any of those 3 collimators, or you can block them, so that if you have a very irregular target shape, you can combine them appropriately. What is shown here is a treatment of a multiple met. Right now, okay, so it's already done. What was shown here is that you can combine any of those 4, 8, or 16 millimeter collimator to treat a target of any geometry. So you have heard a lot from the previous speaker about image guidance. Image guidance is key. You should never treat a patient for SRS and SBRT if you don't have image guidance in place. Having said that, historically, gamma knife users, they did not use image guidance. What they did is they used a frame-based approach for all intracranial treatments, and the patient will have a frame. The frame will be attached to the patient positioning system. So in a way, the patient was a rigid body, if you will. And so there was really hardly any motion. There are some data out there that there's still some motion with the frame in place. So that was then. And the fractions were single fraction treatment. But now recently, Elekta has produced another machine. They call it ICON. And the ICON now offers the possibility, for doing cone beam CT. The concept is pretty much the same as LINAC-based approach for doing cone beam CT. You have I don't have a movie here, but I have put together 4 pictures here chronologically. Here you have a kilovoltage X-ray source and a detector. That's all you need. So here you see the perfection unit, actually the ICON unit now. Here's an X-ray source, and here's a detector. And this rotates around the patient. That's at one point, now the detector is at an AP position. Here the source is there, and here the source is here. So for any cone beam CT acquisition, as we know, that the entire kilovoltage source moves around the patient, and during this rotation, many images are acquired, and from that, one goes back and calculates the cone beam CT. So that's what Gamma Knife Icon has done. So what this has done now, it has opened up a totally new world for the neurosurgeons. They always used to think of a single fraction. Now they'll be thinking of a multiple fraction. They'll be using those the masks to treat the patients. So the next, let me switch gear a little bit. Technology for LINAC-based stereotactic radiosurgery and stereotactic body radiotherapy has improved significantly in recent years. So what that means is the LINACs now are able to really deliver dose distributions that are very highly accurate for all intracranial and extracranial radiosurgery and radiotherapy. What you see here is Variant's edge machine, okay? And this is what I was referring to when I talked about marketing material, sharpen your edge and all that, so please disregard them. So this machine, the edge machine, is Variant's ultimate radiosurgery machine. You'll soon see that in this machine, there is a patient positioning system, or the couch, that has a perfect 6 degrees of freedom motion. Normally, with the conventional linear accelerators, the couch has 4 rotations. It can go lateral, longitudinal, vertical, and a rotation. But this couch has a pitch and roll also. What that does is it allows you to, when you register the cone beam CT to planning CT, it allows you to do a much better registration. And here you also saw some other stuff about the Edge has something called Calypso system and also Eclipse, the Rapid Arc. I'll talk about those in the next slides. So what is Calypso system? The Edge system is really a package system. They produced this machine just to compete with CyberKnife, with the Gamma Knife Perfection and all that. So it's a package system. You have everything in it when you buy it. One of the things that comes with it is the Calypso system that is used to track tumors. The previous speaker, Dr. Verlin, has spoken a lot about motion management. Historically, when we did, for Gamma Knife, whenever we did intracranial radiosurgery, as I mentioned, it was a frame-based approach. But for LINACs, one uses a frameless approach for intracranial radiosurgery and uses a combination of different kinds of immobilization for extracranial radiosurgery. Now, this creates a problem because we know patients move inside the mask, and then also, as you heard from the previous speaker, if a target moves, a lung tumor moves a lot, then there has to be strategies developed how to manage this motion. There are different kinds of strategies. You have already heard about it. There are the tracking techniques, there are gating techniques, breath hold techniques, or other techniques that are out there. So Calypso system that comes with the Edge is a tracking device. So what it does is, here is an example. What one does is one takes 3 small sensors. They're called beacon transponders. They are implanted into the tumor. What I've shown here are 3 beacon transponders implanted in the prostate. So what you do is this control, this array that is placed over the area where the beacon transponders are. So this array then sends a signal to these beacon transponders, an electromagnetic signal, and they communicate. These transponders then respond to those signals at a characteristic unique frequency. So from that, you can calculate the motion of the tumor. So if you can calculate the motion of the tumor, for tracking, what Variant does is what the previous speaker has already shown. It uses the multi-leaf collimators to follow the path of the tumor. That's why it's called tracking. This is shown pictorially, the idea. If you see, if this is your tumor that is moving in a certain direction using the Calypso system that you identified, and here are the multi-leaf collimators. So the beam is on the entire time, and so the multi-leaf collimator is really tracking the tumor. So that's called tracking. The other way of managing the motion is called gating. The concept is again very simple. Gating simply means that if you have a moving tumor, and if this is a profile of your radiation beam, and if the tumor is moving in and out of the beam, what you do is when the tumor moves inside the beam, you turn the radiation beam on. And when the tumor moves outside of the beam, you turn it off. That's called gating. You are gating the beam. And here is an example. Here you see that this is a breathing trace. This is a trace of the breathing of the patient. What one does is, the movie just went away, it will show shortly. Here's the patient laying there, and on the patient there is what the variant calls an RPM system. Here's the camera looking at this monitoring system, if you will, RPM. It has some detectors there. So what it does is watches the system as the patient breathes. This goes up and down. So every 30th of a second, the camera takes a picture of it, that this the detector there moves up and down, so you get a breathing pattern from that. So once you have that breathing pattern, then you decide from that how you are going to treat the patient. So here is shown pictorially. If this is the patient's breathing pattern, you determine within that breathing cycle at what position is the tumor motion very small. Okay? Here you can see tumor goes all the way to the top as part of the breathing and then comes down, deep exhale, the yellow area. So one identify in a phase-based approach, what one does is identifies these 2 points in the, sorry about that. Okay, so basically you see that the radiation beam is on when the tumor comes within the beam, and that happens only when the tumor falls in the exhale phase within that small window. So that's essentially what gating is. Then there is rapid arc. You heard about rapid arc or VMAT treatment. So accelerators now provide machines with high dose rate options called flattening filter-free beams. They also provide capabilities for volumetric modulated arc therapy. Basically what does in a volumetric modulated arc therapy is as the gantry rotates around the patient, one changes dose rate, gantry speed, field shape, all of that, and delivers the treatment. Variant calls it rapid arc, Elekta will call it VMAT, and with that kind of treatment, you deliver the prescription dose in a very much shorter time compared to the conventional methods that one uses. And if you take also the high density or high dose rate beams, which has 2000 MU, what's the time? I think I have some time. I lost track of the time here. So those high dose rate beams, 2000 MU, 2400 MU, or 1400 MU, they deliver the beam at a much faster rate compared to what we are used to, about 400 MU per minute or so. So if you combine rapid arc with a FFF beams, then you are delivering the treatment at a much faster time. What does that all mean? That means the patient is spending a lot less time on the table. And if the patient is spending less time on the table, it's good for the patient. And most importantly, there is less intrafraction motion. And if there's less intrafraction motion, we are able to deliver the dose a lot more accurately to the patient. The other thing these technologies offer is a verification that if you're doing a gated treatment, is the tumor on the day of the treatment exactly where you want it to be? So here you see, this is a profile of the breathing pattern, and this shows this shows when the beam is turned on. Beam is turned on only during this small part of the breathing period. So when the beam is turned on, you want, up here is shown an outline. I don't know whether you can see it. That's the outline of the field, radiation field. When the beam is turned on, the tumor should be within that field. So there are softwares that develop that tells you that if the tumor comes within the field, the outline becomes green, and if not, if the tumor is outside, it is not green. You do a fluoroscopy just before you start treating, just to make sure that the tumor is where it is supposed to be, and then you deliver your treatment. Believe me, we have seen situations that if we had not done this, we would have treated tumors that appeared in a completely different location compared to what we planned the patient for. Then the other machine that I was going to talk about is TrueBeam STX. For all practical purpose, TrueBeam STX is essentially the same as the Edge machine. The difference is Edge comes as packaged. STX is a la carte. You choose what you want to buy. At San Pietro and at UPMC, with our TrueBeam STX, we bought the BrainLab system for monitoring, doing the monitoring during the treatment. Varian will sell you a different product, for monitoring the patient during treatment time. So those are the main differences. Let me move on to the next slide. I'm so sorry. Okay, so here is an example that you see how tumor motion changes with respiration. And I talked about the different techniques, gating or tracking. There is the other breath hold technique as how one can treat these patients or how one can manage the motion. This is coming from the CyberKnife, and you can see that depending on the motion, the software has essentially asked the robot of the CyberKnife where to go and how to deliver the treatment. So this essentially shows how the CyberKnives, the M6, works with the synchrony respiratory system and combines them in a conformal beam and in real-time tumor tracking. So how does it work? The way it works is, I'll take a slight step back. The way it works is you take your imaging panning CT, from there you create DRRs, and then, okay, and here shown is you acquire live images and you put together the DRRs and the live images, make sure that they are exactly the way, aligned the way you want it to be, and then you deliver treatment. During radiation treatment, what happens is there are these live vests, and on top of the live vests are different LED detectors. The camera watches these, sorry, it moved too fast again. So here you have these LED detectors. The camera watches these LED detectors, and from that creates a trace of the breathing pattern. And once you have the trace of the breathing pattern, what you do is you acquire a couple of images at the peak and at the valley of the breathing pattern. And then once you identify that, the system then goes and takes 8 more images. From that, using the breathing pattern, which is a polynomial fit, and the images, it creates a prediction model. You heard about the prediction model. The model essentially tells the system where the tumor will be at a future time. So if the tumor is going to be at time t plus 2 seconds at a particular position, the system tells the robot, go there at where the tumor should be in the future, and then turn the radiation beam on. So the robot then essentially tracks the tumor. So that's how the tracking system works for the CyberKnife MLC. So that's again another method for doing the motion management. Varian is using the MLC tracking. CyberKnife is asking the robot to move and then track the tumor. That's what really the system looks like in. So that's the robotic couch. That's the MLC head, looks like that, and there are cones that are there. You can treat the patient using cones, or you can treat the patient using the multi-leaf collimator. So this is depending on how you choose to treat these patients. The tracking is, as I mentioned here, here is the robot, and the radiation beam is on, and if the tumor moves that way, the robot essentially tracks the tumor. So we are actually the first center in the world, if you will, where we treated the first patient using the CyberKnife M6 multi-leaf collimator. And it has some unique capabilities. Here's an example of a patient. We had 2 tumors, and I'll show you how the system works. Here is N21, that's the position. There were 2 tumors, and here is for a particular robot position with a given XYZ coordinate and a particular field shape. From that position, it turns on the radiation and then changes the field shape segment, turns it on again. Same XYZ coordinate, it's just changing the field shape at this time. And does the same thing again, another segment. And then at the same location, all it did is just change the orientation from the same XYZ coordinate and started to treat the other location for this particular field shape, and does the same for a different field shape. And then it went to a different location and radiates the beam. So it's pretty cute in that sense. And the last machine that I'm going to talk about is the new one. It's a biologically guided radiotherapy. That's what they are marketing this product as. So this is actually a beautiful picture of the planet Earth, taken with a simple camera from the space. What do you see on this image? Different types of lands. The green area are all the forested land. This is the desert land, and that's all covered with ice. What don't you see? You don't see us. We don't see us. We don't see the human activity on this planet. And I'll argue that you can use the same camera, and you can take an activity map of all the humans, of all of us, from the space, and you will not even need a professional photographer for that. Any idea how we can do that? Just be patient and we'll wait till it gets dark. When in the evening, you see the activity will signal itself. You see, this is an activity map of all the human beings, of all of us on the planet Earth. And the important thing is the activity is signaling itself continuously. So how is it related to the machine that I'm going to talk about? That's the analogy to PET. This analogy transcends to anatomic imaging like CT or MRI, which shows you structure, as opposed to PET, which is a biological imaging modality, and it shows you function. It shows you an activity map of the patient or the cancer itself. It is this biological contrast that enables one to target based upon biology rather than the anatomical features that we are used to. So a group of entrepreneurs, they have developed a machine called reflection, and which uniquely combines PET and radiotherapy in a single unit. They will use the PET signal from the target in real time and then use this signal as a biological fiducial. The concept now is changing completely in real time to deliver the radiation treatment. So we have spent some time talking about challenges associated with motion management. Here you see a lung tumor, and this simple radiation therapy process is when we treat these patients, we will fire radiation from multiple different angles, which is good. You know, there's no problem with that. However, the challenges lie when that tumor that you saw starts to move. And as you can see, now the tumor is moving, and as you can see with this beam arrangement, or with that width of the beam, you will not be treating the tumor completely. So that's the challenge. So in order to do that, there are different ways of doing it. We talked about different management techniques. You can increase the margin. If you increase the margin, which means that you make the beam width larger, and I'll show that. So you see that now the green has become wider, and we are essentially covering the treatment of the whole target. So what's the problem with that? The problem is that the minute, depending on the motion of the target, if the motion is very large, your margin gets very large. If the margin is large, in the stereotactic world, we are giving a very high dose of radiation, and we are potentially treating a lot of normal tissue, resulting in a normal tissue toxicity. So we talked about gating, tracking, and all different kinds of methods to manage this motion. This technology, it will be avoiding completely all of that. So how does it work? So this is what the reflection unit looked like. The concept of the machine is very simple. You inject a radiopharmaceutical in a patient, say FDG, and you use the tumor as a biological fiducial. So every pair of photon that comes out of this, you know, if you know the path of this photon, if you have the PET detectors, and if you have a pair of photons that come out, you know, because if you inject FDG, there will be tumor uptake, the photons will be coming from the tumor. And so you know where these photons are coming from. I show here as lines, 3 photon lines. I don't know that you can see it. These are the turquoise lines. So we know that the photons originated there, and these are the detectors, and the photons are coming along that line. So if you know exactly how the photons are coming, then if you can bring a machine to shoot radiation along that line, then you have accomplished it. So the cancer cells are shooting photons at us, and we just shoot a beam of radiation back at the cancer cells along the path of that emission line. That's the concept. What you got to do is do it fast enough so that all the motion management, for all practical purpose, the target seems to be static. So that's one of the challenges. So reflections is a novel radiation therapy system that harnesses signals originating from tumors continuously to guide the treatment beam. So you see that the turquoise lines were the lines along which the photon lines were emitted from the cancer cell. Then I have the green line that shows that I fire radiation just along those lines, right on top of that. So you are really hitting the tumor back. So this will be the last movie, and this is what the reflection system looks like. It consists of a linear accelerator, okay, attached to a ring gantry, and it has 2. Okay, come on. Okay, it went too far for me. So I did not want to go there. Okay, it has. Sorry about that again. I'll try to finish it up. Okay. So you have the PET detectors here. You have a multi-leaf collimator, and you have the LINAC. The collimator is a binary collimator. 2 minutes, okay. It's a binary collimator. It opens and closes fast enough so that you can fire the radiation very quickly to all the emission lines that are coming from the tumor. And the entire system has to move also fast enough to respond exactly to all the emission lines. So let me play the movie since I have short time. Come on. Sorry about that. This is crazy. Okay, maybe this is what I have to do. I advance it. And see, what is causing trouble is I cannot play it. I would like to really show this movie. This is actually pretty cute. See, that arrow is killing me. Whenever I try to bring my cursor to that arrow and oh, okay. So what you see here is the LINAC, the radiation beam coming out, and here are the PET detectors. If you can give me an extra minute, please. Sorry about that. So I have 2 more slides after this. Okay, all right. So the whole system rotates around, okay? And we have to inject the patient with a radiopharmaceutical. Okay, so here is our patient, and this patient can have multiple tumors anywhere in the body, lung or anywhere else, as you can think about a pancreas tumor, whatever that may be. And here you see the multiple tumors this patient has. From a patient perspective, all the patient recognizes that it is going through a PET CT scan. Here comes the FDG. But from a tumor perspective, you'll see that there are a lot of the emission lines that are coming out. And that is shown here now. Shortly, we'll see. So here's the tumor, and these are all the photons that are coming out of the tumor. Okay? So now, with the patient now pulled inside the machine, all these photons are coming out from the tumor, and along the line, you bring every time a line comes out, emission line, detected by the detector, you bring the multi-leaf collimator and you fire the beam. Okay? Then another photon comes, detected there, and you bring the multi-leaf collimator and you fire the beam. If you have 2 tumors, and you say there are 2 trajectories detected by the PET detectors, bring the MLC and shoot the radiation beam at that. So that's really the concept. As you know, you continuously fire the beam at the tumor, and you really don't need the conventional, the anatomic imaging, the OBI, CBCT that we do. You are using the tumor as a biological fiducial. Wherever you see the signal coming from, and you just shoot the radiation back at that. So I've talked about 4 machines, and the question is which machine is best. The previous speaker was trying to tell you got to choose. I'll actually agree with him in many ways. I've talked about an edge machine. I've talked about a perfection machine, a CyberKnife machine, and reflection machine. We always like to say, whatever I have, mine is the best, right? So how do you decide what is best? Those of you who have driven one of these cars, you know they're all good. If you don't know how to drive one of these cars, doesn't matter how good these cars are, they're useless for you. And I see Pierre Carlo just walking in. He has one of these. So a photon is a photon. Doesn't matter where they're coming from, whether they come from a CyberKnife or a TrueBeam or any other machine, regardless of their origin. It is actually, it's all about the expertise of the team. If you don't know how to use that, doesn't matter what technology you have, This is my last slide. So it's a team effort. So the future of radiation oncology, from the perspective of my talk, is it's a team-based approach to radiation oncology, its technology, and its metabolic activity. And the technologies used in the USA are what I talked about, the gamma knife, edge, cyber knife, and reflection. Thank you. Thank you very much.
Thank you very much.
I apologize for all the troubles
In Italy,
that I had.
a magistral lecture doesn't contemplate a discussion. I think only a question for all do. There is a question? No, it's too late.
So we have discussion period at the end, right?
Okay, no. Okay. No question? Possiamo andare avanti, la puoi fare, sì. Sì.
Che guadagno terapeutico tra between CyberKnife with cone and CyberKnife M6 in the dilation we have in
reflection
of the brain. What is
the better? What therapeutic gain with this different machine?
You have only M6 machine?
Yes, I have the M6 machine. As I said, okay. That we are the center who treated the first patient in the world using the multi-leaf collimator that they had. We evaluated their multi-leaf collimator. So what we have found is that we did a study. We actually published a study taking many different intracranial tumors of different sizes and treated them, developed treatment plans using both iris, cones, as well as with the MLC. What we found is, in general, the plan quality parameters are similar with small differences, regardless of whether you are using an MLC or an iris. But where the MLC makes a major difference is, if the tumor is large, your treatment time becomes almost 1/3. So the treatment time for, if I'm using an iris for a particular tumor a large size, if it is 96 minutes using iris, it became almost like 35 minutes using multi-leaf collimator. So that's a tremendous gain. The patient is spending a lot less time on the table, much better patient comfort, and you're delivering the treatment much more efficiently. So that's where the multi-leaf collimator really shines. But for small tumor, there are challenges. And the version of the leaves, the multi-leaf collimator that we had, on which we did the study, that was a 2.5 millimeter. Accuray now has updated that. So they have a new generation of MLC, second generation, and those leaves are 3.85 millimeter wide. And so for small tumors, the plan quality parameters are like conformity index and others are not as good as they will be for using iris or cones. So small mets and stuff, we still continue to treat using either your iris or cones, but for large tumors, we use the multi-leaf collimator.
Thank you very much. Sono stato redarguito perché la sala va...
So I've been reminded that the room has to be left by 6 p.m. So I'm sorry, we have to be on time. Now, Dr. Razza, planning techniques and compared systems. Good evening. Thank you, Dr. Gentile, for this occasion. I'll talk about the eclipse by Varian. I have no conflicts of interest, but I work every day with these machines. This machine is indicated in the upper part of the scheme. This is an example of hardware. It's a network system with accelerators and databases. All the treatments are customized for each patient, and all the treatments and the plans all the rest is recorded on a server. There's many types of configurations for accelerators and the servers. This provides for a connection with a LAN network, and the network is the proprietor of the structure. And this is the case of the several systems connected by a central unit, by internet or other network systems. The contouring is an important part. So here we have magnetic resonance, 2 different patients. On the top, there's a lesion. Down, the lesion is near the trunk. This is the simulation CT and the fusion at the end. This is a rigid fusion. This is the same thing repeated by the PET. This lung nodule. Eclipse allows managing also the gating, different respiratory pathways for the same patient. We can see the target. This is the CT scan at the total expiration. Here they are fused together. Eclipse can manage all the CT scans of all the respiratory stages and can copy all the images on PTV. And it can also create a medium PTV of the selected faces. Here we can see the movement. As to the contouring, Eclipse has several instruments. There's also automatic contouring tools, dose algorithms to calculate the dose for the patient. That's a crucial aspect. Usually models are based on 3 different ideas. The first is based on a model. Usually is the head of the accelerator. It's defined with a Monte Carlo calculation. And then the dose is calculated on other models. Then there is the Monte Carlo, which is a simulation of a physical events by random sampling. In this case, also the patient is modeled by a Monte Carlo, or there's numerical methods that solve the Bosman equation. Other algorithms, as you can read, volumetric dose calculation. The most advanced one are the AAA and the external beams. They can manage many kinds of beams. AAA is based on models. It's very complex. It divides the head in a series of radiations listed in the slide. It also keeps into account the problems of heterogeneity of the tissue. Instead, Accurus XB is based on numerical method for solving the LBT. It uses some approximations. It's very interesting because whereas AAA calculates the dose very well on human tissues, the Accurus also includes or assigns the density to processes or other materials. So generally, a couriers can take all the electronic densities from the CT scan of the patient, and density less than 3 grams per centimeters cubical. The highest mass density instead is 8 GCC. Akuros can also use less time for calculation. It can be used in many fields. And it solves the problem at the beginning. So it calculates when is directly inside the patient. So for any field, it calculates the dose to be delivered. This is an example of the Akuros. It's a profile on the in the center. We have a steel bar from 1 to 7 different materials, plastic and titanium. Blue lines are Monte Carlo calculations. The first is steel, and the second water and steel, and the other is titanium. These are calculations done by us, measurements made with stereotaxis diodes, and then on small fields. And then they are recalculated with the AAA and the Kuros. Matching is quite good, and errors are always less than 2%. These are variant data they used in order to verify the good function of the system. They used the gamma index pass rate, and they obtained higher results are higher than 90%, and Akuros 95% in gamma less than 1. So both were very good. This is a lung lesion. Very different electronic density between the bone and the wall tissue and the lung. Calculation is very well done. No dose reduction on the in the lung. The system provides for a lower electronic density tissue. This is comparison between AAA and Akuros. Dosages are very similar, but there's a difference. So the Kuros is the triangle, AAA is the square. At the center of the lesion, the CTV on the right, there's a small difference on the bottom part. This is a skull. Calculation is done with a AAA of a stereo. It's a 22 gray perfection. The other, it's lesion. The other one is 11 gray. So calculation is very precise. The distance is 50% about the same patient with the other lesions treated in following sessions. These figures shows the first target, the second shows prescription doses, and the third doses at 50% of prescribed doses. So we delivered a raise just in a part of the skull. The system to deliver radiations is very complex. Basically, Eclipse allows contouring with the most advanced manual and automatic tools. It allows supporting contouring on 4D CT, has good dose algorithms, and also allows quality assurance, CBCT review in a very precise and simple way. The system is totally integrated in the variant network, so both accelerators and the database are totally transparent. Thank you very much for your attention. Thank you. We gained 5 minutes.
Nel senso che se non abbiamo tempo la
So the discussion, if the time is not enough, we can have the discussion outside the room. Dottoressa El Gawari. Planning techniques and compared system.
italiana, sì.
Sì.
Good evening, everybody. I'm going to talk about the planning technique of iPlan, which is a TPS of the Brain Lab. And this could be summarized as a suite, that is a system of applications, each of which is dedicated to a specific activity. So it can be an adaptive of a plan, calculation of the dose, the QA or the phantom QA, review, image, and the physics administration. Because every part of the accelerator must be associated to a profile, which is the equipment used to calculate the dose of the plan of treatment. This machine profile is created including data, therefore issued by the vendor, so the profile, the depth, dose, and the out factors, but also it includes features of the accelerators, which can be generally used for the equipment, the limit of the movement of the couch, the multi-leaf features, and specific sections for the algorithm. Specifically for this equipment, it's possible to use pencil beam and also Monte Carlo based on the license available in the hospital. The iPlan has a workflow which is very intuitive and allows to move from a logical step to another, simply following by clicking a next button. This workflow is extremely intuitive because it allows to import the image, import the image, and if there's the possibility of doing, you can merge the studies if there are several studies, then the contouring and planning. Typically, the user is faced with a similar picture in which there are several tabs where you can visualize specific images and specific data, which can be the centralized CT scan used to calculate the plan of treatment, and also other studies, which can be MRIs on various scans or diagnostic CT scans. In particular, this image shows the application which has to do with the contouring section. And you will always see on the top right angle a navigator which allows the user to move from between two logic steps of this workflow, not just forward, but it's also possible to move backwards if some kind of review is necessary. On this side, A tab is available which has all the necessary tool for the current application. In the case of the contouring, you will have all the tools available for contouring. iPlan also has the feature of visualizing all the different studies at the same time, and is extremely useful for the contouring physician because it allows to visualize the contour on all the studies, and this is obviously a great advantage in contouring because it allows to identify the target, and you have in front of you at the same time all these images. The iPlan also allows to export contouring images to another TPS. So basically, in a radiotherapy center, it could also be used as a workstation for an extra contouring workstation should need be. The treatment, or multiple treatment modalities, include a technique that is called circular arc, which utilizes the cones, the conformal beam, which uses some fixed ligands with a multi-leaf linked to the target, an MRT, and then the dynamic conformal arc, and an hybrid technique, which is called hybrid arc. I will not go into detail on plans used with this because Professor Miniti will go more into this. I shall, however, introduce and give you some information on a new application by BrainLab, which is called BrainLab Elements. This is an application used for planning multiple brain metastases. This application is presented like the iPlan. It has different sections. This is the patient data manager, which is the first page that the user sees. There's an acquisition of the images, and there's a multi-layer contouring, and then the plan calculation system. Here it is possible to acquire the centralized CT scan, and the software also has a template that can be used for self-contouring of the iPlan risk profile. The various images must be merged, and the merging technique is extremely efficient, and it does not require a manual review because the outcome is extremely positive. Once the images are blended, it is possible to carry out the contouring with two modalities. One in which you can visualize several studies at the same time, such as the iPlan system, and a second method allows you to visualize a single study and accomplish the contouring directly on a sagittal scan, in which you have a contouring directly in 3D. Once contouring is carried out, it is also possible to access information on the various organs at risk and also on the size of the metastases. At this point, we move forward to the planning. Planning can be accomplished with templates which must be previously prepared. They can be, you can have as many as you wish, and they can be customized. The access to the template is done. These templates are created with this format in which it is possible to decide the dose of treatment and the enlargement of the target if required, and if the target required doses depending on their volume and size. And it is possible to define the position of the couch during the therapy and also the limits of the treatment arcs. So where the gantry must start and where it must be ended. These limitations don't necessarily need to be complied with in the optimization phase, and the arcs could not start and end as planned in the template, because this shall depend on the optimization process. The graphics is extremely pleasant. It's also possible to visualize, once you've finished your treatment plan, all the information concerning the target, the coverage, based on a confirmation index, which gives you all the information on how much this software and to what extent the software has accomplished the desired outcome. This image shows you that should the multi-leaf not have the leaves of the same length during the entire process, in order to have a better configuration and contouring, it is useful and would be more appropriate not to treat the maximum number of lesions, which is 10, but to create metastases clusters, which are more or less restricted in an area, in order for this cluster to be treated in the part with the smaller multi-leaves. This would allow us to have a better contouring of the target volume. The optimization system goes in both directions, go backwards and forwards, and not necessarily one arc is going to insist on all the lesion. This is based on the optimization, which in any case shall be designed to safeguard this healthy tissue. This plan is exported in the machine, and the patient also finds the verification and placement system, which is called Extra-Track 6. And as has been said before, this manages a patient couch with 6 degrees of freedom, 3 translational and 3 rotational. The fact that this system uses an infrared chamber in order to set up the patient, and 2 sources which are placed on the ground with detectors which are oblique. This allows to check the positioning of the patient, and 2 images are going to be used and are going to be matched with digital images which are reconstructed in 6 dimensions. And through the matching performed extremely quickly of these images before the treatment, it is possible to define potential corrections on the position or to the position of the patient in order for him or her to be perfectly positioned during the treatment. The fact that in radiotherapy today we have developed guided radiotherapy has allowed us to use cranial mask systems for SRS and SRT. We now use a special mask by Brain Lab, which is SRS mask, together with Extra-Track. These 2 systems guarantee an extreme accurate positioning of the patient in the region of below 1 millimeter. What I can say at the end is that this system, based on what the physicians and radiotherapists say who work with the contouring is extremely easy because of the fact that it allows to visualize several studies at the same time. The graphics are very good. It does have an extreme fat dose calculation, and it can benefit from Brain Lab products which are not exclusive for this system, which are the exograph and dedicated masks for patient immobilization system for brain lesions. Thank you.
E ora la volta della dottoressa.
It is now the time of Dr. Nardiello, who will review the Monte Carlo system.
Salve, buonasera.
Good evening. At the end of these three presentations, I will talk about Monte Carlo method applied to radiotherapy. What is the Monte Carlo method? It is a modeling of mathematical problems difficult to resolve. The problem is repeated many times in order to have accurate results. So if we can't solve the problem mathematically, we repeat it many times in order to have several results and obtain statistical characteristics, average characteristics of my method. Brief history: the first application was performed to calculate the Greek P. Same experiment was repeated by Laplace. Then, going very quickly, we go to Fermi, who did a random method to calculate the neutron diffusion. Then, in the 40-50s, the Manhattan Project simulated thermonuclear weapons. In this case, the Monte Carlo name was conceived. Of course, since it requires calculation capacity, very high calculation skills, of course, the Monte Carlo method started to be more implemented after the calculators were invented. What kind of applications do we have? We have several applications from financial market simulations, environmental science, astrophysics, and so on. What do we do with the Monte Carlo method in the radiotherapy? Basically, we calculate the dose absorbed in the middle. In order to do that, the Monte Carlo method starts from known areas and then it goes to each particle. So then we analyze all the interactions. So we reach like an average interaction that characterized what we are looking for instance, the absorbed dose. The particles are simulated in the accelerator head. It is simulated in detail. Usually the models are very accurate and complete compared to other models that used very simple models. It is modeled with the measurement tools. Here we have an ionization chamber, and then also interactions in the patient are simulated. In this case, we convert the CT scan images tables with the electronic density of the materials. Here we have one of the several studies proposed with the Monte Carlo method. Compared, the slides compares the Monte Carlo method and others. Agreement is excellent. We can see the PDGs and small profiles. Also, in the penumbra areas, the measurement and simulations are they have a very good agreement. Now, Now with the modern techniques, we need to measure the dose with no reference conditions, so small fields. We don't have electronic balance and dishomogeneity in the passage from the tissue to the lung, for instance. In this sense, Monte Carlo offers support for the validation of standard measurement, usually performed by traditional TPS. The first study that I show you is a comparison between a Monte Carlo simulation and two other algorithms. In patients with lung tumors, so dishomogeneity case. These patients, 10 patients have been studied, treated with the EMRT-IMT technique. They've been randomized with the three algorithms, and then when we compared them, we found a good agreement between the Monte Carlo and superposition and a criticality with a pencil beam that everybody knows in its dishomogeneities. The pencil beam considers a non-realistic target coverage. Usually the target is more covered than it is in truth. The graphics that you see on the right shows a replacement of anything was inside the patient with water. So the dishomogeneities were ruled out. They go in a single result. This way, we understand that maybe the problems were due to low-density transportation means. This other study is about dishomogeneities in small fields. Red lines are 3 centimeters field, the blue 1 centimeter, and black 0.5 centimeters. The continuous line that you see at the bottom is the result of the Monte Carlo. There's a drop-off in the dosage dishomogeneity. The other algorithms here are the convolution superposition and the equivalent path lengths, the other two all generation algorithms, because they use just one dimension. The convolution superposition is the spotted light, more in agreement with the Monte Carlo, whereas little squares above are results obtained with the Bato or the equivalent path lengths. This means that some algorithms are not good for stereotaxic radiotherapy. Last study here, we compare Monte Carlo simulation with the Acuros, XV, and AAA of the Varium. This is because in our center, the Eclipse of the Varium and the iPlan are the machines that we have, and we hold these kind of algorithms. In this case, they are in total agreement. The Acuros, which is quite new, used in very few centers. Instead, the graphic with different results is the AAA, because despite it is a new generation algorithms and good for results in small fields, it doesn't give optimal results in this sense. In conclusion, The two main characteristics of a TPS are accuracy in calculating the dose and the speed of calculation. In TPS, using standard algorithms, we have accuracy problems. We have problems with the small fields, electronic disequilibrium, okay, and inhomogeneities, whereas the speed is the limit for the Monte Carlo. So, for instance, in our center, we have a true beam, a single machine. We do from 40 to 60 patients a day. So we can't calculate all the treatment plan with a Monte Carlo system. What are the solutions to speed up the Monte Carlo? Having high performances in calculation, but this is not easily feasible, or to decrease the heaviness of the calculation. This is a slide that wants to tell us to be careful to the model simplification. Monte Carlo is a statistical model, and if we decrease the number of interactions, the number of particles will modify the result of the dosage. So here we see how the isodose changes according to the number of particles. So the calculation is not really accurate, and solutions are not accurate. So where are we going now? We're going towards hybrid algorithms using Monte Carlo method and also other types of simplifications used by old algorithms. So they're called a fast Monte Carlo and not full Monte Carlo. They are hybrid. They use both techniques, such as a superposition Monte Carlo and so on. Thank you.
Grazie dottoressa, anche lei è stata.
Thank you. You're within the schedule. Now, radiosurgery in brain diseases, machines compared. Professor Minniti will be the first speaker on linear accelerators.
Thank you. Thank you for your invitation. So the topic of my presentation is SRS in brain tumors and clinical outcomes or comparisons. I will make a comparison, and I will talk about the linear accelerators. So I'll try to be good with times. So the outline, the SRS definition, and then treatment planning parameters. SRS equipments that are used, more specifically referring to the SRS Linux, and then advances in repositioning, and what future strategies could be. First of all, we have parameters, we have surrogates of what happens clinically, which we need to consider when we evaluate the quality of a surgical plan. We have different elements, the conformity index, homogeneity index, but the most widely used is the conformity index, which compared to OMAX, which tells us how much we can cover our target and to what extent the dosage is effective, and also the potential toxicity of a surgical treatment. And then we also have a conformity index, which is worse. And when we analyze different treatment plans from different machines, for different machines, we need to consider these indices. What techniques we use? I'll focus on the linear accelerator, the LINAC. You all know the LINAC, a variant and electa, and the true beam. My colleagues will talk about the rest. So we have cobalt sources for surgeries and use of beams with different openings with regard to the gamma knife and the industrial robot arm with a high conformality accuracy. And what you'll see is what happened in the what will happen in the future with regard to the LINAC techniques. So techniques are quite different when we use the saber knife and the gamma knife. We'll see that after. I'll tell you how the LINAC makes us choose between fixed fields, arcs, and techniques that modulate the motion of the sheets. And technological advances have been dramatic. These are softwares that do the treatment planning regarding all platforms and all machines, but more specifically, this is related to the LINAC. So basically what happens with the dose delivery from fixed fields to SRS, so analogous to the IMRT, and modulated arcs, and the most recent technique, the one we use more, the VMAT, so with modulated arches. The other thing that is very important, not all LINAC have, is the multi-leaf collimators. It's not the same thing using 2.5 millimeters or 5 millimeters. When we use 2.5 millimeter sleeves, there is a difference in the healthy tissue that we irradiate, a 10 or 12% difference. So not only the technique, but also the equipment is important. We don't have randomized studies. Mainly we have retrospective studies, so it's difficult to make a comparison. But what we can do, considering the quality indices that I showed you before, we can compare the different plans. This was done comparing with our true beam. We're seeing what we have with the 18 fixed fields, and then here we've been using 6 fields, and this was done using 3 arcs. What we see in terms of conformity index, there is a benefit using the VMAC compared to modulated intensity, and this is also seen in this case. Here we calculated as V12, which is the best index to calculate the toxicity. And you can see there is a decrease, a significant decrease in the healthy tissue that is irradiated at 12 gray. Timing is also different, which is very important. So it's 12 minutes calculated with the FF beam, which allows for significant time reduction. Also here, the VMAT shows a benefit and advantage compared to other techniques. So whenever we can, almost always, there is always a benefit, especially in benign diseases that we treat more frequently with VUMAP compared with fixed fields.
Quello che ovviamente ha cambiato in maniera, ha cambiato anche il concetto della filosofia che c'è dietro la radiochirurgia, che non è più posizionamento, ma è direttamente scintillamento nella
There have been significant changes to the frameless radiosurgery, therefore the accuracy of the positioning. So positioning for frameless SRS and CBC and ExaTac CT. Also this technology for positioning is correlated with couches that not only do translational movements, motion, but also couches that do pitching and other movements. Here you can see when the adjustment is done, not considering the rotational shift, but only translational movements, you can see that the dose can change significantly because target repositioning cannot be optimal. We're talking about lungs or liver, where the organ motion is very challenging, and this is not the case of the brain, but also here we have the problem of intramotion. And this is important because while Combeam CT allows perfect positioning and allows for corrections for patients with a mask, and we're talking about 7 millimeters up to 1 centimeters. But definitely there is a need for readjusting the positioning. But at the end, 5–6% of positionings would have been outside of our PTV. With a PTV of 1 millimeter, there is a part which is 10% that is not adequate. So one of the limitations is that we move the couch and we move the table, and so there is a certain level of uncertainty. So that's the reason why this has been validated. This is a study for Belgium and on the use of extra track, mainly two tubes at 30 degrees so that we can have a 3D reconstruction of our anatomy. In this case, it's the skull. So the first positioning and the setup requires adjustments also within few millimeters. So it's very important that we have this kind of technologies. But then also during the treatment, there are some shifts of 1 or 2 millimeters that must be corrected. And this concerns a significant reduction in the dose at the target. So that's why it is essential, both in the brain and in the spine, to use the extra track. This is another study from Belgium for the validation of this system. So different points that can simulate the lesions in the brain, here posteriorly but also anteriorly. You can see it is interesting to see that unexpectedly the frameless radiosurgery has a lower accuracy, and also it is very interesting that the automated system is slightly lower in terms of accuracy of positioning. So the technician also does it manually. The treatment comparison. Here we have the different techniques. So the gamma perfection. So it's not the last release of the gamma knife with 2 Linac, 2 true beams, and the cyber knife in this study with patients with brain tumors. There was a slight but significant difference with regard to using these techniques. So the index was around 1. Here we use 3 millimeters of leaves. If we have a look at other studies, results are slightly different, but probably clinically there is not a significant impact in terms of outcome and toxicity. When we use the gamma knife for very small lesions, there can be a benefit, but when the target is a little bit larger and more complex, conformity indices are better and compare with the use of the gamma knife. So as far as I'm concerned, with our lesions, there is no specific benefit of the gamma knife compared with the LIMAC. Another study showing the same thing, comparison with the gamma knife, radiosurgery for challenging skull-based lesions. So the conformity indices are better, close to 1. So basically, we can say there is no significant difference. Every center, every institute that wants to implement this technique and requires a robust and long implementation of the technique following all the task group reports from all perspectives, quality assurance, training of residents, as well as the work of technicians and nurses and everyone involved. Future strategies? Are new software that it can improve and optimize our treatments. What should we expect from companies? What technological advances can help us with our work? And today we saw that radiosurgery is essential. So one of the future strategies is to combine new molecules with treatments, with radiotherapy and radiosurgery treatments to surpass the resistance of which is typical of some tumors. Companies try to issue releases to optimize treatment times. This has been tested by us. Basically, optimization can occur in 5-10 minutes from the registration of data with some very interesting tools like a conformity index that we do not like and we can correct immediately. So these are some comparisons that we have conducted. And this is what we have obtained, namely a benefit in terms of chiasma dose, whereas it was within the limits when we use 15 grays for this type of tumor. So there are some problems regarding a single ISO center for multiple brain metastases. We're working on the numbers, but this is a very interesting approach to treat in 20 minutes 8-9 metastases simultaneously, and this is a benefit in terms of timing compared with a cyber knife or a gamma knife. This approach allows us with a single treatment to have an excellent dosimetry. Of course, we still need to optimize the accuracy of the positioning while metastases are distant, and then the single isometric volumetry modulated arc was better, but anyway, we can split metastases, and somehow we can compensate for these deficits. There is a very good consortium on the MRI for image-guided radiation therapy. And this is interesting for readaptive radiosurgery. And this is still ongoing. So we need to continue working and studying on this, because the possibility to improve radiosurgery and radiotherapy comes from DNA damage or angiogenesis, and also the destruction of resistance mechanisms. And this is something that we're doing with immunotherapy. And we can see a dramatic improvement in melanoma. So we're also doing this with the lungs. So we need to focus our efforts on this. From my perspective, the best technology, Linux SRs is equivalent to CK and GK. Thank you.
Flickinger, please. From Pittsburgh, Cyberknife. $15 minutes.
Okay. How do I
Scusate.
Okay, well, thank you for inviting me.
Okay.
Thank you very much. I'd like to speak a little bit about radiosurgery with the CyberKnife in comparison to other modalities. I have almost 30 years of experience with treating with the Gamma knife, but also treat with the CyberKnife and also the TrueBeam platforms, and have used Synergy in the past and have no conflicts of interest. So just some brief pictures on the CyberKnife, and basically the unit uses tracking with X-ray beams from the ceiling, real-time monitoring. The new unit has has a choice of fixed circular collimators that can adjust very quickly, and also the multi-life collimator that Dr. Huck has talked about and already mentioned, that for large targets and multiple targets it's faster, and for small targets and maybe very small targets and maybe less conformal. The strengths and limitations of the CyberKnife are the real-time tracking and positioning of the system. It allows the flexibility to treat anywhere in the body. It's not limited to just the head like the Gamma knife is. It's relatively simple. It has relatively simple, easy-to-use contouring tools that our neurosurgeons like to work with, and also our thoracic surgeons. I find from treating patients with different systems that the patients prefer the mask that we use with that unit is a little more comfortable than for the Linac or the Gamma Knife Icon, because of that flexibility of patient tracking. It's a little bit less tight, and the patients that have problems with anxiety and claustrophobia tend to tolerate it a little bit better, and it's very flexible in terms of patient positioning. Limitations, it's unlike our Linac units, it's impractical for using for conventional radiotherapy for small departments that can't really afford a dedicated machine just for radiosurgery. There's some limitations of the posterior treatment angle positions, but that really doesn't seem to be a problem There's so many other angles available. And the orthogonal kilovoltage imaging depends on radiographic visibility. So if you're trying to count the vertebral bodies in an osteoporotic patient, it may have some difficulty. And that can be overcome with placement of fiducial markers, but that's another invasive intervention that isn't necessary with the cone beam-based CT targeting. And out of the units, for some things that we treat, it may not be as fast as our linear accelerator. And for any of the treatment platforms that we use, any type of treatment over 60, 90 minutes tends to be very uncomfortable for patients. So there are some minor differences in the three modalities in comparison, LINAC and gamma knife, but most of them are not that clinically relevant. And for most things, for relatively spherical solitary targets, they're all equivalent. I do find LINAC systems I do have concern about doing radiosurgery on the LINAC system without the ability of 6D correction with a hexapod table. If you have to treat non-spherical targets that are very elongated, that may pose a problem. If you have multiple technique, or if you want to treat multiple brain metastases with one isocenter, those rotational, the lack of rotation makes it very impractical, and you'd have to add a very large margin to overcome the potential errors for that. For CyberKnife, it does seem to be, it has a lot of appeal for tumors that can move, like in the cervical spine. Patients will be positioned very differently each day in the mask and twist their shoulders and their neck differently, and sometimes exceed the ability of the hexapod tables to correct that deficit, requiring you to take the mask off and do a trial and error adjustment to get the treatment angles or the correction angles for the table within tolerance. So so that's one area where the CyberKnife has some advantages. The CyberKnife and LINAC treatment planning systems have planning software to add treatment margins, which is very easy to do, but that's completely lacking in the gamma knife planning software. So for treatment of a small chordoma where you want to add a margin into the bone, chondrosarcoma, or if it becomes a little more difficult to add these margins. And for the gamma knife, one of the appeals of the gamma knife with the fixed frame system is that because you're using stereotactic MRI imaging with the MR and the CT, if you choose to add that, you remove all of the potential fusion errors between CT and MRI scan to allow you to treat very close to the optic chiasm and for very structures where you're treating like trigeminal neuralgia close to the brainstem. So it's very nice treatment technique for that. But for CyberKnife and LINAC systems, we routinely switch to fractionated treatments where it's less of an issue treating close to the optic chiasm. There are published studies reporting the outcome of CyberKnife treatment for multiple different tumor indications, and to compare them clinically with other systems is just would be a waste of your time here, because they all seem relatively equivalent. So there's a lot of experience with brain metastases, vestibular schwannomas, meningiomas, pituitary adenomas, chordoma, chondrosarcomas, although proton beam historically has been treatment of choice for the skull base. Paragangliomas, small recurrent gliomas after conventional chemoradiotherapy. And we also do radiosurgery for primary lymphoma of the brain in patients that have been heavily pretreated with high-dose methotrexate, where the risk of leukoencephalopathy is very high, particularly in the elderly patients. So if there's a small residual, radiosurgery seems a reasonable choice. We have published our outcome with CyberKnife for vestibular schwannomas, and it's very comparable to other systems. That doesn't seem that much different than the single fraction Gamma knife results, despite the use of 3 fractions. We usually use 6 grade times 3. The other issue I wanted to talk about in terms of some future trends for radiosurgery is the role of radiosurgery in brain metastases that I think will continue to change. So there's recently published data that just demonstrating the relative ineffectiveness of whole brain radiotherapy for brain metastases in the Quartz trial, and that even tumors so that's with non-small cell lung cancer, which I thought seemed to have the best role for whole brain radiotherapy, the best argument that you could make for that. With radiosurgery, we've often felt that the responses to more radio-resistant tumors like melanoma, renal cell carcinoma are so low with conventional whole brain radiotherapy that doing radiosurgery was the only radiation option that really makes sense. And at the other extreme, the patients with breast cancer often their metastases can be very responsive, but they have a lifelong list of continuous seeding and long survival for many, many years. So we feel that trying to avoid whole brain in those patients so that it can be saved for later in case they need it makes more sense, unless they have too many metastases to be managed by radiosurgery or signs of carcinomatous meningitis. So to touch on the Quartz trial, it was just recently published in Lancet in September, 538 patients with non-small cell lung cancer, and they just compared supportive care with steroids to whole brain radiation. And overall, so no differences in those patients, and our hope is that patients will do better with stereotactic radiosurgery. In terms of subsets in that trial, they did have patients that fit into RTOG, RPA class 1 did show benefit. But conversely, patients that were over 70 seemed to actually live shorter lives than patients with just getting supportive care. So always had some concerns about whole brain radiation therapy in the elderly patients. And there's been studies with radiosurgery showing that it's comparing to radiosurgery or to whole brain radiation therapy, that the radiosurgery patients don't run into the same problems with cognitive impairment. Just to touch on some recent CyberKnife studies, there has been increasing use of radiosurgery as treatment for postoperatively for patients, just treating the tumor bed instead of going the route with conventional whole brain radiation therapy. And there are a couple problems in that. One is that there's still a problem with recurrence, and this series just looked at our patients that have had post-op radiosurgery and then had recurrence, and retreating them, what happens when you retreat them a second time, and still have very reasonable results in terms of local control and radiation injury for treatment the second time. And another issue that's come up is is this paper that which looked at 2 institutional treatment policies of treating either preoperatively with radiosurgery or postoperatively to the tumor bed in patients that do need surgical resection, and found in this comparison that in terms of their treatment policy with a post-op treatment, we're treating with a 2 millimeter margin, but hopefully a slightly some reduction in the gross target volume without that margin because of the resection. And then with and in that series found that they were, had a higher rate of what they cited as leptomeningeal spread. And that counted, that doesn't necessarily mean full carcinomatous meningitis disseminated tumor, but any leptomeningeal pattern spread. And often that was very close to the tumor resection bed. So when they looked at that, it was 16% post-operative with post-operative radiosurgery versus approximately 5%. And but the overall survivals were not different, and the overall local control was not different. But they also but they did lower their incidence of radiation injury, perhaps because of the avoidance of that 2 millimeter margin that they were using with the preoperative treatment. And they just wanted to touch on a couple other indications. There's published the best experience with using radiosurgery for chordomas is with a CyberKnife. And there's actually a very large series of Gamma Knife as well, but it's much more highly selected patients and a mixture of recurrences in there. But this is a nice series from Georgetown looking at treatment of chordomas, and most of them were skull-based, but some spine. And I think they recommend 40 gray and 5 fractions, but their median dose was around 35 gray and 5 fractions. And they were able to calculate or estimate an alpha-beta ratio of 2.45, which certainly supports the use of hypofractionated treatment regardless of the treatment modality that you're using in this situation. And there's a similar series from Stanford with their in chondrosarcoma where they should do better, but they were using slightly lower doses, so they don't really measure up to the proton beam results, although perhaps with higher doses, I expect they would. And so in conclusion, I need to keep things short for this, is we do have improvements in the CyberKnife, making it a little bit faster. It's still not the fastest unit that we have, and I think right now, for most things, the fastest unit is the linear accelerator. But it's much more practical now for treating multiple brain metastases because it's faster. And again, I mentioned whole brain radiation therapy really has been shown to have no benefit for non-small cell lung cancer, where we previously thought it really did. So that encouraged us to consider treating patients more and more brain metastases with radiosurgery, and not just giving up and sending them for whole brain radiation therapy when they have more than 4 metastases in the brain. And also that preoperative radiosurgery may be better for patients than postoperative radiosurgery, and that SBRT or radiosurgery in the brain is a reasonable option to protons for small chordoma or fractionated conventional radiotherapy with IMRT for small chordomas, chondrosarcomas, so the skull base and also the spine. Okay, thank you.
Thank you very much. La professoressa Scoccianti ci parla.
Dr. Scoccianti will talk about the Gamma Knife. Good evening. Thank you for the invitation in this day full of prestigious international guests. I'll continue with the different devices. I'll focus on Gamma Knife. This is the list of my presentation, brief introduction, and then those comparisons and I'll be focused on multiple metastases, consequences, and those advantages of this machine, disadvantages, counts of the Gamma knife, and I will describe very briefly the new Gamma knife machine. So we have already said that the Gamma knife is the gold standard for intracranial lesions because radiosurgery was conceived with this machine, and the first clinical model was sold in the 80s. Today, there's about 1 million patients who underwent this kind of treatment. There's a lot, thousands of articles in the literature, so we can actually see how the majority of the articles talk about the gamma knives. And another point to underline is that if we look at the dosimetric studies, gamma knife is considered the gold standard. This is the gamma knife perfection, as we heard in Florence. It was mounted in 2012. We already know all the features and characteristics, and the main thing to be reminded is that the machine is provided with multiple cobalt sources. Every sector has 24 sources, independent or blocked by other sectors and collimators. The pathway of the patient is very smooth. Our OPC includes multiple physicians. The patient goes to the OR in the morning with the local anesthesia. The helmet is positioned. After that, the patient undergoes magnetic resonance, and the treatment is performed. Then the plan is developed, and in the second part of the morning, the patient receives the treatment. The helmet is removed, and the patient is discharged. He will or she will have an appointment, a follow-up in the same multidisciplinary outpatient clinic. The title of my presentation is comparing different machines. It's like comparing different kind of fruits. First thing is a clinical difference to see. So data are not so many, and this is food for thought. There's very few studies collecting many data, multicentric cases that could compare results on metastases for patients treated with the Linac or gamma knife. These are very important data. There's not so much difference, but we're comparing hundreds of patients. And this is something to know. One machine compared to the other doesn't have so many advantages, but maybe we don't have so many data available. I think the comparison should include also dosimetric data. And clearly, all the dosimetric studies are influenced by the skills of the operator and on how the operator is able to use the machine. The accuracy of the machine is the first thing to talk. Gamma knife is characterized by extreme accuracy in each component. Approximative value is submillimetric, and we all know that. As we have already said, Dosimetric comparisons must be based on two parameters, gradient and conformity. Giuseppe said that a conformity index, which is used very often, is the PIV. Ideal value is 1. And the figure 1A, we see the ideal treatment, a superimposition between the target volume and the PIV. The 3 images have index equal to 1. For this reason, the studies have to be compared, keeping into account the coverage and the selectivity. Both keep into account the volumes between the target volume and the prescription isodose. The product is the PADIC conformity index, which I think is the most important thing when we compare different machines. As we have already said, we also talk about the gradient, which is the measurement of the dosage going in the periphery of the lesion. The most used index is the gradient index 50. The image shows the top I put a gradient, optimal gradient, and at the bottom we see that the gradient is less good. Let's go to the comparison. And we know that dosimetric comparisons depend on the skills of the operator. So they are not a real picture of the capacity of the machine. So let's start from this comparison, Gamma Knife and CyberKnife in 2014. This article was published. There's differences between Gamma Knife and CyberKnife in favor of CyberKnife only for conformity indexes. Other indexes are more or less the same. Same article says that the gradient is better for Gamma Knife. And also in terms of volume, included in the different percentages of the isodose to measure the fallout of the peripheral lesion. This is a more recent article, 129 lesions simulated with the 2 treatments. Conformity index is not so different. In this case, it was a PADIC index, whereas Gamma Knife is favored for gradient index, both for the index 50 and for the isodoses outside the target. Gamma Knife versus modulated arc therapy. I tried to include some literature. This is a comparison between Gamma Knife and other radiation dose spillage and perfection. With the gradient index, the gradient is better for Gamma Knife, something which is very evident here. Normal brain is red. Results for normal brain with VUMAT. Blue line is Gamma Knife. This is another comparison with the rapid arc, 19 lesions. The results say the conformity index, according to ARC-TOG, favors rapid arc, whereas the gradient index is better with the gamma. Here we have other indexes measuring the efficacy of the gradient index and other values says that those folds with a gamma knife. Here, only 2 studies, quite old. In the first, they simulated different treatments according to the size and differences among the lesions. And this is a dosimetric comparison of 5 real cases. Same thing, not so much difference in conformality, and the gradient index is better with the tomotherapy. There's also a study that compared Novalis, TrueBeam, FFF, and CyberKnife. The results for conformity and the Paddick index and gradient, keeping into account the volumes of a healthy encephalon with multiple metastases, always favor the gamma knife, with some exception for similar results for conformity and gradient index for TrueBeam. This is the only study that I found reporting a comparison. Dose interplay effect is an additional dose receiving the healthy parenchyma around every lesion treated, and the gamma knife for elevated doses and for low doses is the favored machine. In summary, the dosimetric studies show that gamma knife is the winner for the dose gradient for any kind of index. As to conformity, measuring the Paddick index, it is better or not different than other machines. Instead, the worst conformity is if it's measured with the OTG parameters. What are the clinical consequences? It has the best gradient, the best conformity, and low dose for healthy encephalon. This means less risks for neurological and cognitive problems. The risk of radionecrosis is studied in the literature, and it is represented by the V12. This is the most important parameter for mild literature and intracranial tumor literature. V12 is a very important parameter to understand the efficacy of our treatment plans. Immobilization. The patient has to be immobilized. There are 4 screws, intracranial screws, to be positioned, but things have to be seen from other perspectives, because in this case we don't have to add margins, and this is good for the healthy tissue. And this was shown in an article published in this radiation oncology journal. Another advantage, higher gradient and a higher conformity for lesion in critical sites, and lower dose to organs at risk. The most classical organs and new organs such as hippocampus. Intracranial organ at risk, the classical one, all the cases were done with gamma knife. This is a recent publication on a red journal, including 600 lesions, metastases within the encephalic trunk with very good results for local control and toxicity of patients treated with gamma knife. Another important thing is that a machine with these characteristics has a less extracranial dose, translated in a lower risk of extracranial tumors. Dose can be 100 times lower than for other devices compared to CyberKnife. Up to now, I've talked about patients with brain metastases that have a low life expectancy, but other patients can have a better life expectancy. So these are the advantages. What kind of disadvantages are? Time of treatment, very long, especially if compared with the VUMA treatments, characterized with short times. It's a machine for intracranial lesions. It requires rigid immobilization. It can be used only for single session treatment, as it was already said. The two disadvantages are annulled by the new model of gamma knife recently introduced in the market. It has a real-time optical monitoring, integrated 3D registration and correction system, and the best characteristics is the extreme flexibility. We can do frame-based or frameless in a single session and fractionated session. And based on data, accuracy of the machine seems to be submillimetric, so very similar to the perfection. Thank you very much.
Allora, sono sicuro che le domande potrebbero essere molte, ma dobbiamo andare avanti.
Thank you, and now we need to move forward with the stirrer body, and I'll leave the floor to Marta Scorsetti. Thank you for inviting me. I want to talk about stereotaxy and body stereotaxy. I would like to start by saying that this is an extremely new technique which is giving extremely good results, and this consists in giving a high dose of doses on a small volume of target. This has allowed us to have very good results and high results in terms of local control. So this technique indeed is key and strategic. Obviously, if we need to do an SBRT, we need to take into consideration all the various phases, very accurate multi-imaging system, PET, CT scans, and so on and so forth. Immobilization systems, which also need to be taken into account. We must have systems which allow us to monitor the organ motion. EGRT is also crucial because we give high doses per fraction, and we cannot deliver them to the wrong site. So in the world, in America and in Europe, just to give you an overview on the perfect FBRT, we have the CyberKnives, and we have the LINAC, which is robotic-based, compact, which has already been reviewed by speakers before me. Of course, the Cyber has features which is dedicated to stereotaxy. This system is designed using a compact, lightweight linear accelerator, and that moves around the patients. And for extremely deep lesions, fiducials are still required. Of course, it has a, say, MV energy, and this can be a problem for obese patients. And treatment may take between 30 minutes and 2 hours, and based on the type of cancer and the position of the tumor in the body. So if we have 4 lesions in critical points, we can increase the time. For what concerns Elekta, Elekta and Varian are extremely similar. The systems on the market are available, and these are systems with the CMV but also 10 MV systems. And both Versa and Elekta and Variant use the FFF, the flattening filter formation. Flattening filter free is available, and this allows in only 2 minutes to have an extremely good outcomes. The multi-leaf collimators, and also the possibility of a GRT. This has obviously a cone beam, and it allows a soft tissue visualization during treatment, so it's a very good system. Edge by Varian, this is the equipment that I personally use, have basically the same features. It is able to track the patient's tumor in real time for intracranial and extracranial treatment. So the EGRT, the co-beam, and the tracking system, and the possibility of having optical on the face masking, so we can treat patients with on the cranium, and 2 energies. So 6 MV and 10 MV, up to 24 gray per minute. Both these systems, both Varian and Elekta, offer the possibility of delivering in VMAT modality. And this is extremely important because we managed to give, using all these features, a high dose, 15 to 20 gray in 2 minutes with an extreme degree of precision. So this brings up the question, if we, because we have all this equipment available, if we deliver equivalent ablative doses with FBRT using different systems, can we have a different clinical result or not? Probably it's not different, and I would expect to have not a different outcome because the technical features are different, but if we give you the same dose. Now let's see in the clinical application, the most common ones are lung, liver, and prostate. This is a publication on the JCO which introduces the SBRT in the Netherlands between 2000 and 2007, has brought to an increase of this technique in inoperable elderly patients, with a decrease of patients not receiving this therapy, and an increase of the survival rate, which is obviously crucial. This has become ABR for peripheral lung tumors and the treatment of choice. And take a look at this. This is the main studies that have confirmed the indication to SBRT. The studio by XIA is one of the most well-known, but they all have used ablative doses, and they all have a high local control, more than 95%. And I wanted to take a look at what equipment they have used. Timmerman has used Elekta, Nagata has used Varian, and XIA used CyberKnife. This is a review recently published by our friend Professor Riccardi, prospective studies, again, the results at 13 months and 2 years are similar. From 1 to 2 years, local control are similar. This is a study published on 206 patients with stage 1 non-small cell lung carcinoma. Based on the size of this is a risk adaptive approach. Uses a 3 times 20, 5 times 12, or 8 times 7.5 gray. These are ablative doses, and it uses the Linux variant and has a median follow-up of 12 months and 2 years local control of 93%. This is the famous study by Timmerman, published on JAMA in 2010. It's a stereotactic body gradation therapy for inoperable early-stage lung cancer. It uses the Electa, has 59 patients, a mean follow-up of 34.4 months, and a 3-year local control of 97.6. So it has very good results. In terms of the liver, this is an important aspect for me, and this is an emerging technique. We have a small competence and with the liver, and I think 1 month ago, these guidelines were published by ESMO, which are consensus guidelines for the management of patients with metastatic colorectal cancer. And this was the first time, so you can take a toast to this and raise your glasses. These were retrospective studies and 8 prospective studies. And this shows that our 30, this is our study at the top. Take a look at Stoven, Electa, 60 gray, and a local control, which are extremely similar. This is the study by Rustoven, 25 patients, and again it's SBRT with local control for 1-2 months, with a local control of 95 to 92, and a correlation between local control and diameter of -3 centimeters. This is our study, 71 patients with metastases, or unresectable liver metastases. This was a phase 2 trial, local control of 1 and 2 years, and we used TrueBeam with FFF. This was a patient with SBRT for recurrence of liver metastases after surgery. Again, a metabolic response after 6 months. And this, in my opinion, is fantastic, because the toxicity has excellent rates of local control and, again, low treatment-related toxicity. And this is a final study, again with the CyberKnife. Again, 57 patients with 80 liver metastases enrolled and treated with SBRT using the CyberKnife, grade 1-2 fatigue, and once again the local control can overlap. So this is something which I find to be extremely exemplary. A great example. The prostate is a very important field for us, and radiosurgery and radiotherapy can be a less invasive option compared to surgery, so we must be able to offer it appropriately. This is a very small study, a dosimetric study, and that involves 6 patients with a range of prostate sizes. Again, people using rapid arcs, saying, why don't we try in terms of doses, if giving 35 gray in 5 fraction, the results can overlap. In terms of covering the target and also in terms of the respecting the constraints for organs at risk, we did achieve them in both platforms, and the mean planning and delivery time was in favor of rapid ARC. So in this study, this was able to show us that the IGRT could be used in both randomized studies. And this has been recently published, in my opinion, very important. It's a Ural comparison between the robotic arm versus a gantry linear accelerator. Again, there are some things. The SBRT is recommended for all patients. However, the gantry-based SBRT has larger volumes and shorter treatment times. In terms of a session is roughly 15 minutes with a gantry versus 45 minutes for a cyberknife. And it goes within a daily workflow of patients, and also it can also treat obese patients since they are able to use energies which are higher than 6 MV. These are the studies. We only have 3 gantry based, and all the others are based on robotic arm. These are patients with low risk. Some studies had highlighted intermediate risk. The results basically overlap. The local control at 5 years is really very similar. And these are the features summarized in the article. The fact that the results can be compared in terms of the LINAC or robotic arm. The efficacy and toxicity can overlap, and the time of treatment in terms of from the patient's standpoint and using the gantry, and the obese patients can be better treated. This is our study, which goes in that direction. 90 patients with phase 1-2 study started in 2012 and gives us data of local control, but also of toxicity. And the median follow-up has been roughly 3 years now, and the results are good. SBRT is a radiation treatment that improves clinical outcome and also the patient's quality of life in terms of low toxicity and fewer number of traction. It can be a very interesting alternative to surgery and can be intertwined with RT very effectively. We're having many results of immunotherapy studies which give good outcomes. Clinical data currently seem to suggest that the robotic arm and gantry-based SBRT do provide equivalent or can be comparable with the rates of disease control and toxicities. Gantry-based LINAC seems to be better because it does not require fiducials, or it is not invasive, and has a time of treatment which is extremely limited. This is very important because it falls within the slot of a patient. So in 10-15 patients, I'm able to treat 1 patient of such an important treatment, and I do not need to increase the slots. So these are my conclusions. Of course, we need an appropriate clinical evaluation. Radiotherapy, SBRT, is an extremely valid tool. We can see different types of patients, different types of solid tumors. What we need to do is to decide whom to do what. Every patient is different, every tumor is different, and you can have a different level of preservation. So we must be acute in our choices, and if we decide to do a stereotaxy treatment, we must give an ablative dose. And this is a winner strategy, and this is my message. And delivering an ablative dose requires accuracy, advanced imaging target definition, the possibility of having multi-leaf collimator, managing organ motion, and using FFF. All this will contribute to having good outcomes. And finally, the equipment is important. These type of equipment, the ones I've talked about, are all Ferraris, very good machines which can give outcomes which are exceptional from a SBRT perspective.
Grazie, grazie Marta. È la volta del professor Donato.
Now, Professor Donato, this is going to be the last speaker for tonight.
Thank you. Thank you for the invitation and for the possibility to talk about this subject, extremely interesting subject, especially for the people who use tomotherapy. And as you know, it's another kind of machine. It was not conceived for stereotactic radiotherapy. So a couple of slides for important milestones. First patient treated in 2009 and first patient treated in Italy in 2009. So for us, it was a very big effort for us to use this kind of machine, a completely different, technologically different machine. So it was difficult for us to be able, to use this kind of machines for stereotactic treatment. We don't have equipment specialized for each pathologies, especially in this moment of financial crisis. So we had to use the resources we had in the oncology field. In 2008, this study from 2008 already talked about using a good use of resource in the clinical oncology. So let's see. This is a slide that I asked to the company, and they tell me that tomotherapy is a great system to treat all stereotactic lesions. But is this true? I want to remind you that the basis of the tomotherapy has a very high number of radiant beams, a very good imaging, and that is the main strength of tomotherapy. The helical emission has a large number of beams. We have a high gradient isotropic dose outside of a small volume tumor. And we can also shape the IMRT in large and irregular tumors. This is a very old slide that shows you the sense, the meaning of tomotherapy, a comparison between a normal IMRT and tomotherapy. The dose distribution is circular in low doses. On the other side, it follows the entry beams. So we have excellent conformity beam, and the dose distribution is important. But this is the dose distribution, so maybe this is a problem that will continue to exist. The crucial thing about tomotherapy is that it is an integrated system, coaxial system. The helicoidal system of the source that moves together with the couch, with the bed. This is the best solution of the tomotherapy. In fact, the main reason why the tomotherapy is an excellent machine is the source and repositioning. Then simultaneous treatment, of course, that was a peculiar characteristic at the beginning. And since we were used to see very small targets, very sophisticated targets, we talking about 6 mm target. So the blades, the little leaflet, can't be used. In this case, we have a binary system. So let's go to the advantages. First thing, helicoidal emission, spiral movement, and synergy with a moving couch allows precise treatment because the source is the same. So there's an excellent IMRT, so many beats in tomotherapy, and the system works with the GRT. And this is the basic concept. That's general. I showed you the encephalon because there we see the maximum expression of stereotactic radiation therapy. Let's see the other parts of the body. Given the experience in San Camillo, we can talk about lung and prostate. As to repositioning is very simple. I want to mention this article. We did a dosimetric comparison of the three-dimensional conformal radiotherapy, intensity modulated radiotherapy, and helical tomotherapy, and they were comparable. Maybe comfort index was better in tomotherapy, but the systems were quite comparable. So these are the results for tomotherapy. It gave us these kind of ranges. Other clinical data for organs at risk, an improvement was shown in terms of dose saving in all the considered organ at risks for lung metastasis. Also in low dosage, so there was a very good response. This is a dosimetric comparison. You see, as to the problem of conformity on the target, tomotherapy is good also for all the low dosages indication. But what did we do? We used stereotaxic therapy on the lung, delivered with the helical tomotherapy in 2015. And this article shows, examines the possibility of lung damage after the stereotaxic therapy. This is the distribution. Perfect, no problem, but the DVH respond very well. As you can see, there's excellent coverage. Organs at risk are saved. Where's the problem? Here, if you examine the low dosages, this is what we have in that moment in real time. There's like a bath of dosage. And this can be the problem in tomotherapy. But what did we observe in the preclinical stage? If we have a side effect, actually there is no problem. We know there is this dosage situation, bath and shower effect, but we didn't have acute problems after 1 year. So we consider that technique as a good technique. As to the bath and shower effect, these two lesions were treated simultaneously with different fractions. That was a very good possibility for tomography with 2 different dosages set differently. And obviously, there is a problem if we see all the radiations we have delivered. Our experience showed that on 52 patients admitted, we didn't have any criticality except for 1. We had excellent response by the patients, no in-field progression. A pseudo-correction was diagnosed. So excellent experience. This is a classical case, quite a rare event, a case of diffuse consolidation pattern. But now the patient is okay, is healthy. And now, the future, we joined our strength together. We have very important numbers with our experience. And we joined our strength with Professor Perugia, with the professors from the University of Perugia for future publication. Prostate, we used it on a very few number of patients with recurrence after radiations. So we had a very good technology. We published this study with this kind of possibility, and we also used an hydrogel space between the rectum and the bladder, so that the prostate was free from, and the organs at risk were also free from the area of treatment. This is the situation that was shown. Those patients could be irradiated properly. Our treatment, 6 grays multiplied by 5, excellent response in all patients who underwent the treatment. The only problem was that in 2 patients there were no response, but they were irradiated after 2 years, 2 years following the first treatment. So the problem is not, the problem is just the disease. The disease was already mature, was diffused, so that didn't make any sense. So what is the conclusion? Tomotherapy, I think, has excellent possibility of image-guided system. The patient is easily positioned. Of course, we also have 51 fields of rotation, so we can irradiate all the parts that we wish. So treatment of multiple lesions in the same application, good versatility to treat any section of the body, but be careful of low dose. And the last line is the crucial thing. Be careful about clinical benefit. Here we can see a perfect treatment, but you can see a new metastasis after 3 months. So maybe the clinical aspect is the most important thing at the moment.
Thank you, Vittorio. As Cinderella at midnight, we need to leave everything, but we need to be ready to flee. If there's one question, we have one question here. This is the slide which I didn't show. I must say that it's not important what equipment you use, but since when the center is doing radiotherapy, since how long you've been working on this, the fraction and the dose. Basically, nobody will tell Messi what shoes to wear when he goes to play football. So I agree on this. Thank you.
Sì, stasera.